Good morning.
Good morning.
How is everybody?
Good.
Good. We are on class 4. That means at the end of class today, you have reached the halfway point. It goes fast. It goes very fast. And if you think the first 2 weeks went by fast, the next 2 are really going to fly by. So make sure that you're keeping up with your homework, because if you fall behind, it becomes really, really difficult to catch up because now you're fighting time. Okay. So try not to fall too far behind on homework if you have challenges outside of class, which most of you do. You'll also want to make sure that you're practicing these skills. And we don't have a lot of time in class to practice because I have so much to tell you. So a lot of your practice will be outside of class. So make sure you're practicing as well. Okay, good. You had chapter 4 to read between last class and today, and then you had the test on page 184 to take and grade. So when I call your names, let me know either how many you missed or what your score was. Akayla? Do you have 2 and 3 for me?
Yeah, I got 100 on both of those two.
Perfect, thank you. Felicity? Felicity, do you have 2 and 3?
2 was 95 and 3 was 100.
Thank you. Jamie?
95.
Thank you. Peyton? Gloria?
95.
Kenley? Zarina? Melissa?
100.
Okay. Tosh, see here. Nancy?
95.
Jasmine?
100.
Jose?
90.
Jose, do you have 2 and 3 for me?
I do. Chapter 2, 100. Chapter 3, 95.
Thank you. Alani?
100.
Amelia?
95.
Do you have 2 and 3 for me?
Yeah, chapter 2 is going to be 85 and chapter 3 is going to be 90.
Thank you. Isabella? I hear. Okay. All right. Any questions on what you missed? Any questions? We're going to do a quick review. Now, when I say quick, I'm really going to try to move through this quickly, okay? Because this should truly be a review of what you read in chapter 4. But chapter 4 contains a lot of information, and it tends to kind of tangle students up quite a bit because you're trying to figure out, okay, how much of this do I really need to know for the test? Is the test going to ask me what body system the lungs belong in? And no, they're not going to. That's not a test question. Now, those of you that are going on for nursing, you will have years of anatomy. You actually have to take an entire year of anatomy 1 and 2 with lab before you can even get into the program. And then you'll have pathophysiology, body systems, human growth and development, all of those types of things that will have to be covered as well. So you're literally going to have years of education on chapter 4. At the CNA level, we just need you to have an awareness that different neighborhoods in the body do different jobs. But it's like a city. You can have different neighborhoods in the city, but together they're going to make up a whole city. And that's really how the body works as well. So if we have a problem in one body system, chances are it's probably going to affect other body systems as well, because everything is interconnected. Make sense? Good. All right. So there's 10 major body systems. There's actually subgroupings as well, which we're not going to get into. What you need to know is that each one of these does something specific, and every single one of them is going to be affected by aging. Every one of them. So what are the effects of aging? And that becomes very relevant to us as CNAs, primarily because we work with the aging public. Most people don't need help, right? You guys are all independent. You don't need somebody to come to your house and brush your teeth in the morning. You're independent. Most people are independent. But as we age and we experience the effects of aging, we might find that we need some help with certain things. And that's really where the CNAs come in. Now, that doesn't mean that CNAs don't ever work with younger people, but it's just not going to be your major focus. The majority of people you care for will be older. But CNAs can be hired to work with pediatrics. Pediatrics would be not healthy children, obviously. They would be children with long-term medical conditions, things like spina bifida, muscular dystrophy, cerebral palsy, brittle diabetes, children that need a little bit more help than their parents are able to provide, and they're in the medical system. So you might be providing this assistance in their home. You might be providing this assistance in a medical daycare, and we actually have one here in our county. And they're moving. They just renovated a facility on Forest Oaks, and they're moving into a much bigger facility. And they are hiring, by the way. If pediatrics is your thing, look at tender care, because they are hiring prior to moving into their new setting. But for the most part, most of what CNAs are going to focus on are the elderly, or those that are younger but very ill or injured. So since the elderly is going to be kind of our biggest playground, we kind of have to know, okay, well, I know that bodies are affected by aging, but how specifically are they affected? What are some things that I should expect to see? Because you have to know what's normal in order to be able to recognize abnormal. And abnormal is what we report. Make sense? So that's what I want you to focus on with Chapter 4. So we're going to go through these body systems really quickly and talk about what happens in that body system normally as we age. So the first one we're going to focus on is the nervous system. This is the control center of the body. Everything is affected by your brain, spinal cords, and nerves, okay? Everything in your body is affected by this. And like everything in the body, it's going to age. Your brain is not the same right now as it was when you were 6. Your brain has aged. It has changed. And your brain will keep changing as you go through life. Well, we have to think about the things that the brain does. And one of the big things that the brain does is it makes memories, and it stores those memories, and it's able to recall those memories when it needs to. Well, if the brain ages, right, and the brain makes memories, that means that the brain's ability to make memories is probably going to be affected. And we see this quite often. Somebody can remember they wore to a piano recital when they were 12, but they can't remember that they just had lunch. Now, in your mind, you're like, hey, Zia, he was from my last class. He actually works at Tender Care. Okay. So as a young person with your brain not affected by age, you might be really frustrated with that. You know, George, we just had lunch. How can you not remember that we just had lunch? Well, it's because the brain that's making those memories right now, it's not working so well. Okay. Does that make sense? So don't get frustrated with your older patients when they have memory lapses. It's perfectly normal. If I were to invent something like this pen and I wanted to go to a factory and have a factory make this pen for me to sell, and I toured 2 factories. The first is brand new, state of the art. Everything that comes off the assembly line is great quality. There's no problems. It's super efficient, right? That's a good factory. Now, if I went and toured a 90-year-old factory where all the gears are rusty, some of them are missing teeth, the stuff only works about half the time, what kind of pen is that factory going to produce? Yeah, not as good quality, right? Well, we have to remember that's kind of like the brain. When the brain gets to be 70, 80, 90, yeah, the springs are all rusty. It's missing some gears in there. Might be offline right now. That's all right. Give it some time. It might come back, right? That's kind of a very visual example of what's happening in the brain. And we have to be careful not to get frustrated with our patients because they don't have the same thinking capacity that you do. Because at some point, you will also be trying to think with a 90-year-old brain. If you're lucky enough to get there. That's right. Yeah, the alternative, way worse. Make sense? But there's more that this is going to affect. Because the brain kind of controls everything, right? All body processes that are regulated by the brain are going to be affected here. It also affects your nerves. If you touch a hot pan, your hand will immediately let go of that hot pan because your brain recognizes that, hey, that hurts. And those signals are able to move through your nervous system to your brain pretty quickly because everything is still in good condition. But as we age, those pathways tend to degrade. Things move a lot slower. So our patients might pick something up that's hot, not realize it's hot right away, and not put it down right away because that impulse didn't get where it needed to go quickly. And now they're at higher risk of burns because they held on to it longer. Does that make sense? This is also going to affect our balance and our coordination. So you might be walking on a flat surface just fine. Everything in you is working good. But when your patients, as their muscles start to age, and we're going to see this in just a few minutes, they degrade a little bit. And their feet may not hit the floor flat like yours do. They might hit the floor at an angle, which means now they're off balance. And it may take us a little bit to correct that balance, which puts us at a higher risk for falls. Make sense? Okay. Every part of our body ages. Now, the cardiovascular system is another part that ages, and this is pretty high up on the list because you're going to see this quite a bit with your patients. A lot of times as we age, we end up with high blood pressure, and that's just because the pipes in our body get gunky, just like the pipes in your house. They get gunky. Stuff kind of collects on the inside of them, and now we don't have as much room in the pipes. So there's more pressure inside and gives us higher blood pressure. But we also might have low blood pressure as well with elderly. Now that's a totally different reason. That's because the heart is just tired. It's tired. It has beat about 70 times a minute for your entire life. No coffee breaks, no vacations, no time off for good behavior. It has shown up and done its job consistently throughout your entire lifetime. And by the time you get 70, 80, 90, it's tired. So it's just not going to beat as efficiently, which means that you could end up with a lower blood pressure because the heart's just kind of phoning it in, right? Just Make sense? Good. You'll also have effects in your, where are we at? Respiratory system. So this is where your lungs inflate and deflate, brings in oxygen, gets rid of carbon dioxide. But all of those little air sacs inside the lungs, we call them alveoli, not ravioli, alveoli. Although they kind of look like ravioli. Yeah, they're like little pillows. So they get all gunked up. And part of that could be lifestyle, right? If you have smoked, you've gunked up your pillow sacks in there. But it can also be from environmental, right? We breathe in a lot of chemicals, smoke, exhaust, things like that, that can over time affect the inner workings of your lungs. You do that for 70, 80 years, and your lungs probably aren't going to inflate the same way they used to. But it goes beyond that, because at the bottom of your lungs is a muscle called a diaphragm. And that diaphragm actually pushes up to push air out of your lungs, and it relaxes to let your lungs inflate, right? But it's a muscle. And we're about to find out that muscles are going to be affected by age, all of the muscles in your body, including your diaphragm. So your diaphragm, as you get older, may not be able to push all the air out of your lungs, which means you're holding on to carbon dioxide a whole lot longer. That's an acid. And if our body is holding on to carbon dioxide, it's not going to be able to pick up oxygen. So your patients are often, as we age, shorter of breath quicker. Where you might be able to walk 3 miles and not get short of breath, somebody that's older may only be able to walk to the bathroom without getting short of breath. And it has to do with the ability of the lungs to expand, contract, inflate, deflate, and then exchange gases during that process. Good. So we have to be patient with our older patients. We also have the endocrine system. The endocrine system is kind of one of my favorite systems. It's one that nobody really pays attention to. Everybody just ignores it. Go off, do your job. You're the unsung hero of the body world, right? But the endocrine system, without it, you wouldn't last 2 seconds. Would not last 2 seconds. Your endocrine system produces hormones. Now, we've all learned in 5th grade sex ed or 7th grade, whenever they're teaching it now, that hormones make the world go round. And we tend to focus on those sex hormones, right? Testosterone, estrogen, progesterone, those types of hormones. Those make up less than 1% of the hormones that make your body run. We have other hormones we have to think about, like insulin, ACTH, thyroid hormones, leptin, human growth hormone. There's a lot of other hormones in your body that regulate all of the processes. They're like our little chemical messengers that get stuff done. And as we age, these hormones are going to be affected. They aren't going to be produced, or if they are produced, they're not going to be produced well. Or if we have them, they may not be able to get to where they need to go because there's roadblocks. So things start to wind down. Now, you guys are probably all pretty familiar with the concept of thyroid. We've all kind of heard about this, right? Thyroid is what gives us energy, helps our metabolism work properly, that type of thing. Well, what do you think is going to happen if our thyroid hormones aren't working adequately? How are we going to feel? Tired, sluggish, sure. So when you walk into your patient's room and you say, okay, Miss Daisy, it is now time for your shower. And she goes, oh, Lord, no. I cannot, no, can't do it, just can't do it. Your brain is going to say, well, what do you mean you can't do it? I do all the work. All you got to do is sit there. I mean, but we have to understand that just sitting up takes energy, right? Make sense? This is usually what's going to be very impactful on your patient's activities of daily living. Now, insulin is another hormone that's going to affect your patient, because insulin is what we need to metabolize or break down certain foods called carbohydrates into sugars for your cells to use. If we don't have good insulin production, your cells aren't going to get fed. And again, that's going to make you tired. You starting to see why old people are always tired? We have the urinary system. This one's going to impact you quite a bit. Bless you. This is going to make you want to curse out your patients. And if you don't understand this, you might curse out your patients. So I need you to understand this so you don't. Okay. When you're young, you can hold your urine for an impressively long time. When you're young, good morning. When you're young, you probably have had this situation. Oh, I think I need to go to the bathroom. I'll go in just a minute. I got to get this done first. And then hours go by and you realize, oh, I had to pee. I got to go pee now, right? Yeah, you can't do that when you're older because that muscle, the bladder muscle, is not strong enough. It does not stretch enough to put it off. So when your older patients say, oh, I got to go to the bathroom, they don't mean when it's convenient for you. They mean my bladder is not going to wait. I have to go. Now, if you don't understand that, if you are thinking about this from your own experience, you will mistakenly think, oh, my patients can wait for me. No, they can't. That's your bladder, not theirs. Don't make that mistake. Your experience is not where they are at, but there's more. That's bad enough, isn't it? Right? That bladder just doesn't stretch. It also, because of the loss of bladder tone, doesn't contract either. So when you go to the bathroom, there's a gravity component, right? You go to the bathroom, a valve opens, the urine falls out because of gravity. Okay. But there's always a point where you kind of have to give it a little extra push to finish her off, right? Well, that's your bladder contracting to empty completely. Well, if we've lost bladder tone, we're not going to be able to completely empty our bladder. So now we're starting with a half full cup. So how often do you think your patients are going to need to go to the bathroom? A lot. Are they going to be able to wait? No. Okay, now the valve at the bottom of the bladder, which we're going to learn about next week, the valve at the bottom of the bladder gets kind of floppy, sloppy. It's a muscle. Doesn't work as well as it used to. So we can have a little bit of leakage as well. Make sense? Now, if we, as good CNAs, get our patients to the bathroom on a toileting schedule, usually every 2 hours around the clock. Means we're waking them up at 2 a.m. Come on, Miss Mary, let's go to the bathroom. If we do that every 2 hours and before meals around the clock, what that does is it's like you going to the gym on a regular basis. It is consistent exercise of that muscle at the base of the bladder, making it open and close at a very specified regiment of time.
So you can set it on a timer?
Yes. And when you do that, it strengthens that muscle, but it also kind of trains the body. This is when we go. And it can help strengthen kind of that whole system. We call that bowel and bladder retraining. And it can be very, very effective to reduce incontinence in older patients. But your older patients will probably have to go often. And that can be very frustrating for CNAs because that's what we do. We do toileting. And your patient will ask to go to the bathroom. You'll go to the bathroom. And then 20, 30 minutes later, again, they're on the call light and say, I have to go pee. And you're like, I just took you. Yeah. And you know what? You're going to take them again and again and again, right? Penalizing somebody for the effects of aging is kind of stupid. Make sense? Good? right? Then we have the integumentary system. This is the part of aging we see. This is very visible, right? Our hair color changes. We get dark spots. We get wrinkles. The skin is dry. It's thin. It tears easily. This we see. So it's easy to see, oh, that's an old person. If I showed you two pictures, you could pick out the old person pretty quickly because of how they look. And this is kind of what we focus on with aging, right? Oh yeah, they're old. They look old. But with what you see, you have to remember that it's like an iceberg, right? That's just the tip of the iceberg. That's only what you see. The effects of aging go way, 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 way deeper than that. And if it's that visible to us that we can pick it out through a photo, can you imagine all of the effects on the inside of the body that are occurring? Getting old is no fun. They call it the golden years. My aunt calls them the rust years. I think that's probably more appropriate. But don't forget that just like beauty is only skin deep, the changing, in order to be beautiful, you have to be beautiful on the inside, not just the outside. The same applies to aging. Aging doesn't just apply to the outside of the body, it also applies to the in. And that's why we have to go over this. Then we have the reproductive system. Yeah, this is pretty self-explanatory. As hormones, actually not always, no. The hormone levels do decrease, but that doesn't mean the sex drive dies. It doesn't. And just like with any other part of the population, you have a scale. Some people, when they're young, are highly sexualized, right? And then there's other people, same age, same situation, that are less sexualized, right? There's a spectrum of sexualization. Same thing when you're older, right? There are some older people that have absolutely no sex drive, no interest. I'm done. Thank you. Hung that hat up a while ago. I'm good. But there are still a huge portion of the older population that still enjoy a healthy sex drive. And that's perfectly normal. Okay. So don't walk in that room unless you've knocked. I used to bring that up, but then I got some hate mail. Yeah. So yeah, if you ever have any doubt that elderly sexualization isn't alive and well, go check out the villages. Yeah. Don't take any bath scrunchies with you. All right, then we have the gastrointestinal system. This you will see effects of, and it might not register with you what's happening in the body. So let me kind of demystify this. When we get older, every part of our body is affected, including your stomach and intestines. So your stomach isn't going to process food as quickly. It slows down. So an older person can eat a meal and then be like, yeah, I'm done for a while. They eat less. They eat less because as digestion slows down, the stomach is filling up and it's not going anywhere. So older patients often eat less. They generally tend to want to eat their bigger meal early in the day because there's a lot of indigestion that happens when you eat a big meal and then try to lay down because of gravity. They're at risk for constipation because food is just not moving through the intestines very well at all. But this is actually affected by our next body system. And a lot of people don't understand this because they don't look like they go together. They just don't. What do you mean that one has something to do with the other? So remember that your intestines are a muscle, but they're a smooth muscle, which means it doesn't really contract on its own. It requires outside help. And the outside help comes through our musculoskeletal system. When you walk, when you move, when you reposition, when you turn, when you sit, when you shift, all of that moves your abdominal muscles. All of those movements of the abdominal muscles pushes the food through your intestines. So you guys are pretty active. You're young. Everything is working well. So you move, you get up, you walk, you get in and out of your car, you clean your house, you wash your dishes. All of that action is moving your abdominal muscles, which in turn is moving food through your intestinal system. So what do you think happens as we get older and we get tired, which we've already talked about, and our muscles get weaker and we spend a whole lot more time sitting? What do you think that's going to do to your digestion, your digestive system? It slows it down. Now, we already know it's slow from just being older. And now we're going to add to that very little abdominal contraction because of our lack of movement. So those two systems, believe it or not, go together like peanut butter and jelly. Does that make sense? We used to, years ago, and this kind of goes along with what you were saying before we went live. Years ago, before we knew better, we used to take our old people in institutions and put them in bed. And we left them there forever. But in their case, forever didn't ever last very long. They generally, when you make somebody bedbound, generally speaking, their life expectancy goes down to about 4 to 6 weeks. So we had to figure out why. Why? Just because I put you in bed, why did that automatically? I mean, you don't have cancer. You don't have anything that should kill you. Why is that killing you? And what we found out is that if muscles don't move, every body system gets affected. The secretions in your lungs start to harden, and now you're at risk for pneumonia. Your food isn't moving through your intestine, and it allows it to stay there and stagnate. And now we can end up with not just constipation, but leaky gut syndrome. Your bladder isn't emptying completely. Remember that gravity thing? Well, that's all part of constipation, yes. Your bladder not emptying correctly can predispose you to urinary tract infections, which then is a direct effect on septicemia, okay? Because the bladder infection goes to your kidneys, kidneys filter blood, we have a direct blood contact. Now that bacteria can move throughout your body. Your muscles break down. Your skin opens with bed sores. Now we have another opening for pathogens. So just putting somebody in bed and leaving them there is a death sentence. This is why we generally don't let people stay in bed all the time. Very, very, very few care plans will have the patient on bed rest forever. And if they do, those patients have to be turned on a regular basis to get those muscles moving even passively. But generally speaking, if I've got a patient that can't move on their own, we're going to use a Hoyer and get them up into the chair because that's going to move the muscles. It opens up the lungs, allows good air exchange. Gravity will let the urine come out. It'll be a much better completion. Digestion is in the right position, right? So putting somebody in bed and leaving them there is the worst thing in the world you can do for a person. Does that make sense? So musculoskeletal system is definitely affected by aging, and we need to recognize that. So we're going to bring in things like range of motion exercises that we learned last class. Good? Good. Lymphatic system. This is your recycling system of the body. Sometimes fluid gets into places it shouldn't be. It happens. Usually because of what we call dependency, gravity. So if I'm sitting in this position with my feet down for a long period of time, I have to have enough strength in my heart when it squeezes to push that blood, not down. Down is easy. Down is gravity. Gravity is just going to pull that blood down to my feet, no problem. But I got to have enough pressure in the system to push that blood from my feet back up to the heart. Now, if my heart isn't working so good, if it's really weak and just I'm going to end up with a whole lot of blood in my feet that isn't going anywhere. So that's going to cause a traffic jam. A lot of blood in my feet isn't going anywhere, traffic jam. We call that swelling. Now, what happens, the reason swelling occurs is inside the vessels, you got liquid and you got cells. Well, when we have a traffic jam, we got to make room, so we throw out the liquid. You can't throw out the cells, they're too big. Cells stay, liquid gets pushed out to the tissues. That's the swelling. That's what you see. Well, that swelling is a symptom. It's a sign. It says, hey, there's a lot of cells in this vessel with no liquid in it. What do you think that could do? If you got a lot of cells that are sticky and no liquid to dilute them, what do you think might happen?
Swelling.
Okay, swelling. Sticky cells clump. Blood clots. Sticky cells clump together. So when you have swelling, that means the fluid that's preventing those sticky cells from sticking together is not inside the vessels anymore. We push the liquid out to the tissues. So now we got a whole bunch of sticky cells in the vessel and no liquid to dilute it. So we are at risk for blood clots. Okay, see that? So our lymph system is the system that goes around and collects all of that excess fluid that's now in the tissues where it shouldn't be, puts it back into the blood vessels where it should be to help prevent those clots from occurring. This system doesn't work so well as we age. So if we have swelling, we may not be able to reduce that swelling as quickly as we should be able to. And we may possibly be at higher risk for blood clot development as we age because we're not getting the fluid out of where it shouldn't be and back into where it should. So a lot of your older patients will have what we call TED hose or compression socks or stockings. And that's exactly what this is. It's to help this system out by providing external compression that keeps that fluid in the vessels where it needs to be. It keeps that fluid from leaking out into the tissues. Sure. Gravity. Yeah. Now, when you elevate your feet, that means that your feet have to be higher than your heart. And this is, a lot of people get this wrong. They get into a recliner. Okay. So recliners do not elevate your feet. Sure, it looks like it does, right? Because your feet are higher than your butt, but your heart's not in your butt. Your heart's up here. What we need is our feet higher than our heart. So if we're in a recliner like this, your heart is not lower than your feet. It's actually uphill because the blood comes down to your butt and then it can't go back uphill. So when we are elevating feet, this is what I'm talking about. You guys see that? This is not comfortable. Your patients don't like this. They want this. So it can take a little bit of finagling to get our feet higher than our heart for it to have that effect. Okay, you're welcome. Good? Questions? All right. Those were the 10 body systems and how they affect aging. That's the type of information that you need to know. So you might have a test question that says, You are caring for a 90-year-old patient and assisting them with eating. What is a important consideration for the CNA when caring for this patient? Okay, so I want you to remember everything that we just talked about. So A would be keep the patient immobile for 2 hours after eating. B, make sure the patient eats all of their food. C, provide light activity after eating, such as range of motion exercises. Or D, force fluids. C, because we would know that activity helps with digestion. Good? Makes sense?
Question about that. Swimming. When people go swimming, they always say don't eat around that, but what's actually that? Would to me seems like not true. After eating, you should maybe swim.
Okay, so you're right track, wrong train. So the answer to that is, and first of all, they've pretty much debunked that theory. Okay, and I've seen some conflicting research on that, but they pretty much debunked it. But let me explain to you why. And it's not because everybody thinks, okay, I ate a hot dog at the theme park. Now I've got to wait 30 minutes before I even dip my toes in the water. And that's not what it is. You don't want to be in a position where the water is over your head and you have to engage your core muscles to keep yourself buoyant. Because when you're engaging those core muscles to keep, with treading water and stuff, when you're engaging those core muscles, remember those muscles are important in digestion and we want them to be engaged. That's great. But when you're working them that hard, you're actually pulling resources from other muscle groups. Now, swimming is a fantastic exercise, right? Because it engages the entire body. I'm not talking about, in the shallow end, splashing some water. It's not. I'm talking about full body swimming, right? Where you're not touching the ground in any way. You have to use all of your muscles for that. Well, when you do that, generally speaking, you may end up with some sort of a cramping situation, whether it's abdominal cramps or leg cramps. And when you're eating, you're already full. That whole area is distended. So when you get cramps, it can actually be quite debilitating and it could result in drowning. Okay. Now, again, I'm not talking about going to the water park in the wave pool up to your knees and splashing around. That's perfectly okay. Up to your chest, perfectly okay. It's when you are engaging every muscle in treading water aggressively or full body swimming, you can end up with that cramping situation because you've got a lot of the resources that are going toward food digestion that we really would need in muscle activation. Does that make sense? Okay. So it's kind of a misnomer. A lot of people don't go near the water. Yeah, that has nothing to do with it. Water doesn't have anything to do with this. It's the fact that we don't want you to end up with electrolyte imbalances that cause muscle cramping and you drown. Anybody catch the game show yesterday? Anybody catch the game show? Good. Okay. If you are unsure of the types of questions that you might have on the state exam, the game show is a great way to kind of get a sneak peek into what you're going to be asked on the state exam. And yesterday I covered questions that are kind of what you guys would think are on the state exam. Okay. Some of the previous ones have covered topics that you have no idea they're coming. So you might want to go back and watch some of those. Okay. All right. To review quickly, a pulse is a measurement of how many times the heart beats over 1 minute. Normal is between 60 and 100. We don't use our thumb to take a pulse. We use 2 fingers, fingertips, not flat areas of the finger. Pulse is located at the very top of the thumb side of the wrist. Put your thumb on the back for consistent pressure. You're going to count what you feel under your thumb for 1 full minute. but we're always going to count as long as the care plan tells us to. And sometimes the care plan will tell us to count for 1 full minute. We always report it over 1 full minute, but sometimes we can take shortcuts. We can just count for 15 seconds and multiply that by 4. Or we might use a pulse ox to take a pulse. Perfectly okay. Go by your policy and procedure for your facility and your care plan for your patient. If your patient's pulse is irregular, what do I mean by that? Well, a regular pulse comes at a normal interval. We expect it. You can kind of set your clock by it. This is regular. It is a rhythm. It is a pattern. If I stop, you could fill in the next one. Right? Irregular is not regular. That is an irregular pulse. If you count that for 15 seconds and multiply that by 4, you're not getting anything accurate because it's not regular. You can't anticipate that this same amount would be in the next 45 seconds, right? So irregular pulses are counted over 1 full minute. Good? Very common with our older individuals. A lot of our older individuals, about half of them, have something called AFib. And that was the rhythm, the last one for AFib. It goes really fast and then disappears and then really slow and then kind of in the middle and then all over the place. And sometimes it's really hard to count because sometimes the fastest can be really, really fast. Like 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. This is AFib, and what that means is the part of the heart that tells the heart when to contract is kind of offline. It just not working right. So the heart contracts very irregularly. Now, we have a medication that we give these people. However, and they have to have this medication every day, and that strengthens the heart so that we don't have blood pooling in the heart, and we reduce the risk of blood clots in the heart. Now, this medication, though, slows the heart rate down. For the most part, it's fine. I don't care about that. But if my patient has a starting heart rate of only 60, and I'm giving them a medication that's going to slow it down, yeah, we can end up with a patient that their heart isn't beating fast enough to sustain life. This is the number one reason that CNAs are asked to take a pulse. I need a pulse rate every day on these 12 patients. Every morning before 9, I need these 12 patients' pulse rates. And that's because at 9 o'clock, I'm going around giving medication. I've got to look at that list, see what their pulse rates were to figure out, can I give you this medication today?
What medication is it?
Digoxin. Yep. Which 200 years ago was, I probably shouldn't tell you that. All right. A lot of the medications we use, we found out about them quite by accident because they were actually used as poisons several hundred years ago in an unregulated dose. So, dressing a resident with a weak arm, we learned how to do. We remember this by USA First, undress strong arm first. You want to ask the patient what clothing they want to wear. You want to provide privacy while you do this. You want to make sure all of the clothing is arranged neatly. They look good at the end. Just take care of them. This is not a hard skill. As long as you know to undress the strong arm first and dress the weak arm first, the rest of this is all about how do they look? How do they feel? Pay attention to your patient, not you. Okay, good. This is not, this is probably one of the easier skills. A lot of students get all tangled up in this one. It's not hard, as long as you're paying attention where you should be, to the patient. Okay. Hand and nail care, mani. Soak the hand, wash the hand, rinse the hand, dry the hand, clean under the nails, wipe the orange stick off in between so you're not taking stuff from one nail, putting it under the other, and then file the rough edges of the nails. Lotion on last. We're going to warm the lotion up and wipe off the excess. That's the whole skill. Do we put soap in the basin?
No.
Who has to check the water?
The patient.
Yep. So you already know everything you need to know about that. Look how far you've come. Making an occupied bed, we change the bed a half at a time. That's all we're doing here is changing the bottom sheet a half at a time. Minimize wrinkles. But the way we do this is to remember clean rolls toward me, dirty rolls away. Okay. Any questions? Range of motion. Just follow the recipe. Range of motion is going to tell you what body part, what exercise, and how many repetitions. Just do that. That's the whole skill. Flexion extension is up, down. Abduction, adduction is side to side. And the way you remember that is if you abduct a child, you take it away from its family. Don't do that. That's bad. But abducting an extremity, you take it away from its family. Okay. Good? Good. Talk to your patients through this, guys. You should never be moving a patient's body part unless they know where you're taking it and why. That's just a good principle. Never move a patient's body part, any part of them, unless they know where you're taking it and why. Because what's going to happen is that they will unintentionally resist. They will stiffen, they'll pull away. If I reach over and grab you right now, grab your arm and start pulling you, you're unintentionally, I mean, you know, I don't have your, I'm not going to hurt you. I don't have any nefarious intent, but your body is going to react to the fact that somebody is grabbing you and you don't know why. So talk to your patients, tell them, I'm going to lift your arm above your head like you're asking a question. Put an action to it that they will recognize. Good? All right. So look how much you've learned. Any questions so far before we move on? You will have another review next week on class 5 Monday and class 6 Wednesday. But Wednesday is our last review. And I want you to kind of tuck that information in the back of your head. It's a fast review, but at the beginning of class 6, if you want to review for the test, the first hour of class 6 is going to be a pretty comprehensive review for you before testing. Good? All right, so let's learn sideline position. A lot of what we're about to learn is something that I just introduced to you, so this will go pretty quickly. So if you turn to page 138 in your books, you can see the overview of this particular skill. Wow, I am shedding today. All right. So if you look down here at the side, you can see all the principles that are involved in this skill. They're all spelled out for us here. The short version of the skill is up here. And I actually had somebody say, you think 14 steps is short? But yes, when you look at the full step-by-step, this is the short version. Skill-specific steps here, we're going to get to those in just a minute. And then down here is your test information. So somebody with your level of experience, which is none, should be able to do this skill in 8 minutes or less. And all we're going to do here is turn somebody on their side and prop them there with pillows. That's what we're doing here. We're going to use these principles to get it done. This is a live patient skill. You might be the patient in the bed for this skill. That person will be positioned in a bed. So when you're practicing this, you should be practicing it on a live person with that person in a bed to get a good feel of how this is going to go for the state exam. This is your instruction for dress rehearsal. Good. All right, page 139 has our step-by-step instructions on it. At the top of the page, you'll see the care plan. It says position the resident on his left side. Patient requires support to remain on his side and is unable to assist with turning. What do we know about the care plan?
If the patient's not going to help us, they can't scoot over.
Okay. I'm going to have you hold that thought for just a second. Let's go back just one step. Okay. So we have to follow the care plan, right? And it's the care plan, the whole care plan, and okay. Some of you, your brain just added to this care plan without you being aware of it. What does that very last sentence say? Does it say they're immobile? Does it say they cannot scoot? What does it truly say? They can't turn. Do you see how your brain kind of switched that a little bit? Do you see that? Okay. You've got to be really, really careful not to let your brain change these words, because you just made that into a totally different patient. Make sense? Good. Okay. So I like to give a visual example of this for students to really kind of get behind. Okay. So imagine for a moment that you had abdominal surgery and you were cut from here to here, and it just happened yesterday. So you have, lots of things kind of holding this together. You got some stitches on the inside. You got some tape on the outside, probably an abdominal binder to hold you all together, right? Now, you're not going to be able to move this side of your body over because your abdominal muscles aren't even talking right now, okay? So you're not going to be able to roll onto your side. You can't turn on your own because you got to have abdominal muscles that are talking to do that. So you can't turn, but you could scoot. Right. You could move your butt because your butt wasn't cut open. Right? Make sense? Okay. So there's a lot of other examples I can give you, but let's just kind of keep it simple with that one. I don't know what your patients are going to be like out there. You have is going to be a little bit different. Every single one. You can have 3 patients with the exact same surgery. Exact same surgery that are going to have different care plans, because their specific needs are going to be a little bit different. I'll give you an example. All 3 patients had abdominal surgery. All 3 of them. We cut them open. One of them just had a hip replacement the week before. Is that patient going to be able to scoot? The second one just had abdominal surgery. We cut him completely open, and he is an amputee above the knee, previous from diabetes. Is he going to be able to scoot? And then we've got you. Can you scoot? Probably. You can probably lift your butt up and move them over. Sure. However you need to do it.
I don't know.
Yep. Yep. So there's no restriction there. Doesn't tell me you can't. Good? Does that make sense? I can't overstate this enough. You guys in your brain will immediately assign a level of ability to your patient that may not be correct. It may not be correct. Good? So we follow this exactly. The nurse doesn't have time for every single patient to take you aside and say, okay, listen, you're going to be turning this patient onto their side, but this particular patient, they can lift their butt, they can scoot towards you, or this particular patient has diabetes and they don't have time. That's why we have the care plan. They write it down once and everybody gets to follow it. But you may not always understand the why behind the care plan. Okay? You don't need to follow it. Good? Good. All right, so we got some step-by-step instructions. We got supplies at the bottom. Memorize your supplies. So this is our care plan for this particular skill. Position the resident on his left side. Where am I putting him? Left side. That's going to be important in a minute. Patient requires support to remain on his side, which means gravity will probably pull him back. He doesn't have the stability to keep himself on his side like you do. In bed, you probably turn on your left side. You can stay there. Perfectly okay. Your body can fight gravity. All your muscles work just fine. This patient, for whatever reason, he's going to roll back onto his back. Gravity always pulls people back onto their back. It's just gravity. It's kind of like room temperature. It's a law. So we're going to use some pillows to keep them on their side, keep gravity from pulling them back. I'll show you how to do that in a minute. And we're going to use these principles to accomplish this task. These are some things we need to know about this particular task. So let's get into it. All we have to learn is skill specific. We know all the rest. We know to follow the care plan. We know to do our opening. We know to evaluate if we need gloves. We know to use a barrier on the table. Our patient's going to be uncovered, so a privacy blanket would be a good idea. We know not to hold anything against our uniform, use what we take, dispose of anything we don't use. We also know the patient must be in the middle of the bed. We learned that last class. And we know how to do the closing. Nothing there to learn. We know all of it. We're good. But we do have to learn a little bit about the skill-specific steps, things we need to know about sideline position itself. But before I get into that, we want to review side rails. And we have to remember side rails are a restraint. So even though we're turning this patient on their side, and they're certainly not getting out of bed, we're not going to use side rails to keep them safe. We're going to make sure they're in the middle of the bed to keep them safe. Good? Side rails are a restraint. You cannot use a side rail unless you have a doctor's order. Did I tell you guys about the nursing home that drugged their patients? Night shift? Yeah, drugged them. So many years ago, there was a night shift in a nursing home that drugged, as soon as they came on shift, they drugged every single one of their patients with Benadryl, put them all in bed, put the side rails up. And they would sit in the break room and play cards and watch TV and nap and sleep and do all of those things. And they actually had a very high injury rate on that shift. Because patients, now Benadryl affects your coordination. It affects your balance. It affects your cognition. It drugs you. And these patients would climb over the side rails and end up falling. They had a much higher rate of falls, and that's actually what got them caught. They're a very big reason why we have the side rails are a restraint rule. Because before that, anybody could throw side rails up. We didn't care. That's horrible. What's even more horrible for me, how many of you guys have an extra $6,000 in your budget every month that you just have nothing to do with? You just throw it into a savings account somewhere. You wouldn't miss it. Nobody, right? That's a lot of money. $6,000 a month is a lot of money. If you had to pay somebody $6,000 a month, what kind of service do you want for that?
Exemplary.
Absolutely. I don't even spend that much on a vacation. And I expect, massages and flowers and, right? The cheapest nursing home in the United States is $6,000 a month. The cheapest nursing home. Most of them are right around $9,000 to $12,000 a month. The patient has to pay that out of their own pocket, out of their own money. Nobody is paying that for them. Nobody.
What if they don't have that?
If they've exhausted all resources and they have no money, then they can apply for Medicaid. But they have to have no money, none. That means that they've sold their house. We've already burned through that money. They've cashed in their stocks and bonds. They've sold their cash value life insurance. They have no money. None. Then they can apply for Medicaid. Now, something you guys probably don't know is that Medicaid just had a huge budget cut. And the biggest demographic that this budget cut is going to hit is the elderly in nursing homes. They don't have a home. Remember, they sold it. They don't have any life insurance. They cashed it in. They have no money. And in a lot of cases, they have no family, and now they're about to be homeless. These aren't people that can pinch a tent in the woods and live okay. These are people with advanced medical needs. I don't know what's going to happen. So when I give you that story about the night shift that drugged their patients and put them into bed with side rails up, now that you know that those patients had to pay $6,000 a month to be abused, how does that make you feel? Angry?
Sick.
Remember that your patients are paying to be there. They're not a byproduct of what we do. Nobody is, it's not free. Nobody is handing you money for this. They work their whole life. When they were in the middle of working overtime, do you think it was ever in the back of their minds that, oh, I got to sock up enough money so I can pay for my nursing home later? This isn't what they wanted to spend their money on. They wanted to be in Cancun with a margarita. I don't blame them. That's what I'm saving for. But the vast reality is that you're never going to make it to Cancun, that something catastrophic medically is going to happen, and the medical system is going to take every penny that you worked hard to squirrel away. They're going to drain you dry. And along the way, you're going to have a whole bunch of healthcare workers that don't give a crap about you. They're going to treat you like garbage while they drain you dry. You're starting to see why your older patients might be a little bitter, angry, upset that it took you 3 hours to answer their call light and they just defecated themselves in their bed, and you walk in and they throw something at you. Our immediate response is, oh, that's a bad patient. But if we start looking at it from their side of the bed, things change. What we do matters, but it's actually more important how we do it. Good? Make sense? Don't rely on side rails to do your job of safety for you. Half rails are not side rails. They're positioning rails. This patient can still get out of bed. This is not a side rail. This is okay. But let's talk about immobility, because some of you guys put that in the care plan. You know, your mind kind of went there, right? So let's talk about immobility. This patient isn't immobile. Our care plan doesn't tell us they're immobile, but we often turn immobile patients. So I want to talk to you just a little bit about what that means. Immobile means that they cannot move on their own. It doesn't necessarily mean paralyzed. It could mean a muscle weakness. It could mean a recovery from a surgery that keeps us from being able to move independently. It could be something wrong with our brain at the moment, like meningitis. It could be a long-term chronic thing. It could be a short-term thing. But immobility means the patient has difficulty or is unable to move one or more parts of their body. Now, when your patient is immobile, we have already talked about how important it is to have mobility, to move around. It affects every single body system in your body, from your brain to your lungs, to your digestion, to your muscles, to your bladder. Every body system is affected by your ability to move freely. Good. So if you're unable to move freely, everything is going to be affected. So we've got to take that into consideration as nurses. One of the biggest body systems, though, that is going to be affected by immobility is the skin. Now, I'm going to explain to you how this works, and I want you to play along with me, okay? I know this is going to seem a little weird, but I want you to play along with me. For the next 2 minutes, and I'm only going to ask you to do this for 2 minutes, I want you to sit on one of your hands. Place it under your leg. I'll tell you when to pull it out. You're going to want to pull it out before I tell you to. Please don't. Please play along, okay? So let me explain to you what's happening here. In your body, you have bones. Bones are heavy. And those bones press down on whatever surface you're on, because gravity pulls everything down. So when you're laying down on your back, your skull, your shoulders, your elbows, your hips, the back of your thighs, the back of your calves, and your heels are all being, those bones are being pulled down. Good? Make sense? All right. Well, why do we care? Well, because in between that bone and the surface is all of this. You've got a layer of muscle, you got a layer of fat, you got a layer of skin, and in between those are blood vessels. So as the body weight pushes down on all of these layers, it compresses them. And as it compresses them, it actually closes off the blood vessels, crimps them like a straw. What do you think happens to areas of the body that don't get blood flow? Yeah, they start to die because we're not getting oxygen, we're not getting nutrients. Now, if you've got a surface underneath you that has any texture, any wrinkles, any crumbs, any irregular surfaces, that is going to press up into the skin. So you've got body weight coming down, you've got these irregular surfaces pressing up, and what's in the middle? Well, everything that's important to you. Your skin, your muscles, your blood vessels. If you have pressure from below and pressure from above, squeezing these areas, and we crimp off those blood vessels, we end up with something called a pressure sore. And it doesn't take long to develop. Pull your hand out and take a look at it. Do you have color changes? How many of you guys have color changes? Look really, really close at the surface of your skin. Can you see the pattern of your clothing or the chair embedded in the surface of your skin? Guys, that was 2 minutes. 2 minutes. And you have already gotten imprinted with a pattern because you had, what's that? Yes. Yeah, it happens when we sleep too. That's because you've got pressure from above and pressure from below, and your skin and tissues are trapped in between. Now, thankfully, you are healthy, young, have good circulation. Those lines are going to resolve themselves, no problem. That's exactly right. That's where I'm going with this. Imagine, okay, if it only took 2 minutes for you to get lines and color changes, imagine what would happen after 24 hours. Imagine what would happen after just 2 hours if 2 minutes did this. And that's how pressure sores are developed. Pressure sores are when we leave a patient in a position without changing, without relieving that pressure for an extended period of time. That pressure, which left red areas on you, gets deeper and deeper and deeper and deeper and will eventually cut the skin. And that is how a pressure sore is developed. So when we have a patient who's immobile, unable to move on their own, your care plan is going to tell you to change their position at a certain interval. Usually it's every 2 hours around the clock. That means we're waking them up at 2 a.m. Yes, it does. And what ends up happening is there's some CNAs who are very well-meaning CNAs that think to themselves, I'm not going to wake up Mr. Jones. He's been so tired lately. Remember, tired, old. I'm just going to let him sleep through the night. And they don't change the patient's position, thinking they're doing a good thing. Well, that pressure never gets relieved, and it gets deeper and deeper and deeper, and it cuts into the skin and then through the muscle and up to the bone. And we end up with a pressure sore. Pressure sores only take about 2 hours to develop. And in some cases, they can even occur quicker than that. They can be very bad. They can be. So when we have somebody who can't move on their own, your care plan is going to tell you to change their position at a specified interval.
What if they won't let you?
What?
If they say, I don't want to be turned?
Okay, what do we do with that?
Tell the nurse.
Tell the nurse. So you already know the answer to that
Yeah.
question.
Just making sure you're on your toes.
Yeah, we tell the nurse. That's right. So generally speaking, our care plans are going to tell us to change this patient's position every 2 hours around the clock. But remember I said that gravity will always try to pull somebody back onto their back. That's because most of our weight is distributed along our back, you know, the back of our head, our shoulders, our butt, lower back area. We have more weight back here than up here. It's just weight distribution. So gravity always tries to pull somebody back onto their back. What we can do is use some pillows to keep that from happening. So we're going to turn our patient every 2 hours around the clock or as often as directed in the care plan. Now, I actually had a trick question on yesterday's game show. And I asked, how often do you do catheter care? And we haven't got to that. We'll get to that on week 4. But the answer, I put the choices in a very specific order on purpose because everybody got stuck on answer 1 or 2. They thought, oh, that's the right answer, and they picked it. And the very last answer was as often as directed in the care plan. That is always the right answer. I don't care what the question is. As often as directed in the care plan is always the right answer. I don't care what you think you know about these skills. These skills don't apply to this patient unless the care plan says they do. Good? Makes sense? So I just told you, we are going to change a patient's position every 2 hours around the clock. So if I gave you a test question that says, how often are we going to change the patient's position? And the answers were every hour, every 2 hours around the clock, as often as the patient requests, or as often as the care plan tells us to, what are we going to choose? Care plan. Now, generally speaking, it's every 2 hours around the clock, but this patient might have a specific situation that needs it done more often. If you go by what you think you know about the skills, you're not taking care of this patient. Good? Make sense? So to answer your question that you said at the very beginning today before we went live, you're right. It really is all about the care plan. Good?
Questions about crease. You mentioned creases due to the pressure
Mhm. Right. And when we made an occupied bed, that was something that I mentioned, to pull the sheet tight under the patient to remove as many wrinkles as possible to get that sheet as tight as we can. And this is why. So we want to try to minimize wrinkles. Now, there's a body in the bed. We're not going to be able to get rid of every single wrinkle from underneath the patient. It's very difficult to do, right? Because there's a body in the bed. But we want to remove as many wrinkles as humanly possible. We also want to look for things like crumbs, remote controls, cell phone chargers. You know, the little end of a cell phone charger, right? Not attached to a cell phone, but that little metal end that you plug into your cell phone. That's a hard surface, unyielding. If it gets trapped underneath your patient and you don't catch it, it will bite into the patient's skin and can easily cause a bed sore, a pressure sore. So look under the patient, what's there. So when we're turning somebody every 2 hours around the clock, we have to talk about, okay, what position do they need to be in? How do I turn them? We always start out with the patient on their back. That's the kind of the normal default position, right? This is where they start. And then 2 hours later, I'm going to turn them on their right side. 2 hours later, we're going back to the back. The back doesn't have as many blood vessels, and it's okay to repeat that position every other turn. 2 hours later, left side. 2 hours later, back. Right, back, left, back, right, back, left, back. Never on their stomach. Notice nothing on here was on their stomach. And that's because if your patient is truly immobile, they lack the nerve innervation and the muscle strength to lift themselves off of their chest cavity for their lungs to inflate. And you can suffocate a patient by putting them on their stomach. Isn't that horrible? So stomach is not on here. But if your care plan did include stomach, you would include it for that particular patient because we always go by the care plan. And what we found during COVID, and this was really interesting for those of us that follow this kind of stuff, and I'm a geek. During COVID, there was a nurse in an ICU that was really having trouble with her patients getting good oxygenation, even on a vent. There was just not really good air exchange, gas exchange. So she tried an inverted position, turn the patient over onto their stomach, but she used a special bed that kind of suspended them so that they're with a strap here and a strap here, so their lungs were able to inflate. They didn't have to fight gravity. And she actually found that prone position on their stomach actually resulted in better gas exchange. Their levels increased. So she reported that. They did some studies and they found that in certain situations with certain biomarkers that were available, they could predict which patients might respond better to a prone position. So those care plans would have said, turn the patient every 2 hours around the clock, but back, right, stomach, left, back, right. And we're going to follow the care plan. Good? Make sense? All right. This is called a turning clock. You might have these if you have an immobile patient up on the wall. If, as a nurse, I walk in at 2:15 p.m. and I look at the patient, this is my PM clock, right? At 2:15 p.m., my patient should be on their back. So I can look at this, look at my patient and go, cool. My CNAs are doing what they need to do. CNAs can put a turning clock up. If you don't have one, you can put one up. Perfectly okay. That is within your scope of practice. Keeps everybody on the same page. Good. Interestingly enough, I hate this statistic, but the most dangerous place for an immobile patient in regards to bed sores, the most common place for an immobile patient to develop a bed sore, do you know where it is? Do you have any guesses? Okay, I'm not talking on the body, I'm talking about facility. Yeah, so the most common facility type for a patient to develop a bed sore would be
Nursing home.
A skilled nursing home.
hospital. Yep. A lot of people think home because the family members probably aren't turning the patient the way they need to be. Second would be skilled facility because you got a lot of patients and not a lot of staff, but it's actually a hospital. You have a much higher chance of getting a bed sore in a hospital than any other setting. Well, the problem is, yeah, so if we have an immobile patient, the staff isn't they're focused on immediate needs. They're not really focused on preventing a bed sore. They're focused on what has brought our patient here. Where in skilled nursing, we take a more holistic approach. We look at real and potential problems. Now, the nurses in the hospital should be looking at potential problems too. That's why they're there. It's part of nursing, but they often don't. So, hospitals are a very real threat to immobile patients. And this happens a lot. Patients get transferred from a nursing home to a hospital for a problem, a fall or whatever, and they will come back with a bed sore. Yeah. So those of you who are going on for hospital work, if you're going to go work in a hospital, I want you to remember this, please.
And rehabs will accept you from the hospital if you have a bed sore.
That's right. That's right. All right, so just remember, we have to keep our patients in the middle of the bed. Even when they're turned on their side, they have to be in the middle of the bed. So we're going to scoot them toward us and then turn them. Now, if they can't scoot on their own, your care plan may tell you to use a draw sheet. We talked about that. If you can't scoot on your own, the care plan may tell you to move your patient in segments, right? Move their head and shoulders, their torso, their hips, their legs. If you can't move on your own, the care plan may tell you to use a slide sheet, which are really cool things. They're like NASA technology. It's very slippery material that you put under the patient, and it almost levitates them. I mean, you can just slide somebody right across it with no friction. It's great. But they're very expensive. And in most settings, if your facility even has one, it's probably locked up in a manager's office and you've got to sign it out and promise to return it and all this kind of stuff. So they aren't used very often because they are so expensive.
So we use a draw sheet.
You would go by your care plan. That's right. Because there's a lot of situations where a draw sheet is not, it's just a regular sheet. But there's a lot of situations where a draw sheet isn't the right solution. If you have a patient that has compression fractures in their back, multiple compression fractures, that pulling motion, that cradling motion with the draw sheet can destabilize those compression fractures. That may not be the right solution. Make sense? Okay. So you would have to go by your care plan for that patient. One of the things you have to understand, guys, is that, let's say, the only way it's so hard for me to explain this, to describe this, okay? This is probably the hardest thing that I have to get across to you, and that's why I keep saying follow the care plan, follow the care plan, follow the care plan. If I selected a movie that none of you had ever seen before, none of you had seen, it's a movie that, I don't know, you never seen the movie before, and I played a 30-second clip of the movie, and that's all you got to see was a 30-second clip of the movie, and then I asked you to tell me what the plot is, would you be able to do it? Would you be able to tell me what all the problems they were going to occur and how it was going to resolve? No, because you're only dealing with just that little 30-second clip. That's all the information you know. You could say, well, it might do this or this might happen, but you have no idea, right? So that's what it's like to be a CNA. You have a 30-second clip of knowledge about this patient. That's it. That's it. The nurse has seen the whole movie many times. So the nurse is going to tell you, okay, this is an important part. Pay attention. Don't go to sleep during this part. This is good. right? They're there to give you that this is what you need to know. Heads up. That's what the care plan is. If you just start making stuff up, you're not telling me about the movie. You're telling me about your version of the movie. Does that make sense? That's why it's so hard for me to get this concept of the care plan to you. Because you'll watch that 30 seconds of the movie and then think you've got it. And you don't. So that's why I keep saying, follow the care plan. Follow the care plan. And I sound like a broken record. But if it gets you to follow the care plan, I've done my job. Okay, good. All right, so your patient should always be in the middle of the bed even after they're on their side. You can use a draw sheet. Sure, absolutely. You can also use a slide sheet. You can use the segment method. You could use anything that the care plan tells you to use. And if the care plan doesn't specify, you can use whatever you want. Good? Questions? All right. For the test, though, if we go back to our care plan, it just tells us the patient cannot turn without assistance. Right? They need assistance with turning. Doesn't say they need assistance with scooting. They just can't roll. So you can ask them for the test, hey, can you scoot toward me? And you know what? They will. That's ideal. That's amazing. Makes our job so much easier. Good? Questions? But what if you're in a clinical setting, care plan doesn't say anything, just has you reposition the patient. You ask the patient, hey, can you scoot toward me? And the patient says, I haven't moved since 1973. Now, you got to scoot the patient toward you. If you're not sure how to best accomplish that, who should you ask? The nurse. That's right.
Just out of curiosity, in that situation specifically, the care plan is not mentioning this disabled one that's been from 1973. At that point, immediately, you should not even moving them and consulting the nurse. No?
Well, no, okay, so let me back up here, right? We've got a care plan just says reposition the patient every 2 hours. That's all it says. Nothing else, just reposition them every 2 hours. So you go in, you don't know the patient, never met him before, and you say, hey, can you scoot toward me? And he says, I haven't moved since 1973. I had a motorcycle accident. I've been paralyzed from the neck down since then. First of all, kudos to him because somebody's been taking really good care of him to keep him alive that long. Good job, right? Good job. So in that case, I would probably ask the patient, hey, how do they normally scoot you before they roll you? Care plan doesn't give us any guidelines, right? It doesn't tell us how to do it, but more importantly, it doesn't tell us what we can't do. Okay, good. So I'll ask the patient, hey, how do they normally do this? I don't know you, never met you. I got a couple options, got a couple tricks up my sleeve. Which one do we want to use? Okay. Patient will probably say, oh yeah, they just use the draw sheet. It's under me. Use it like a sling. Or I got this one guy that, man, he just pushes me to the side really quick and he's really strong. So that works. And you might think, well, I'm a strong guy. I can do that too. Now, if you're not sure, if the patient can't tell you, if you know, you're like, hey, listen, I'm just not comfortable with this, you can certainly call up the nurse, say, hey, how do you want me to move this guy? It's not on the care plan. And the nurse is going to say, I don't care. It's not on the care plan. Knock yourself out. You want to use draw sheet? Don't care. There's no what we call a contraindication. Care plans, for the most part, you guys look at them as a CNA. You look at care plans to tell you what to do. That's your job. That's your role. That's exactly what you're supposed to do. That care plan is your instruction sheet, tells you what to do. But that's actually not why the nurse wrote it. That is not how nurses create care plans. Nurses create care plans to tell you what not to do. So when you see a care plan that says use a draw sheet, what I'm really saying is slide sheets, segments, those are no good for this patient. This is where I want you to stay. For the nurse, the whole world is open. So I'm telling you what I want you to use because I don't want you over here. Does that make sense? So if the care plan doesn't have a specific instruction, what that means is the nurse is like, hey, the world's wide open. Good?
Contradictory though. Nothing but the care plan.
That's right. That's right. But if you start to understand that, and you'll eventually, when you get out there and start working, this actually becomes pretty clear to you. So when you get out there and you start working, you start to realize that a care plan is really, it's there to give you instructions, but it's really there to restrict the wrong movements. Okay, good. So I'll give you an example. Ambulate with a gait belt. Okay, so we have a care plan that tells us to walk the patient using a gait belt. Patient can walk, they just need some assistance to stand. That's our care plan. What that tells you to use a gait belt, right? That gives you some direct, that's what you're going to use. It's what the care plan told you to. You're going to follow the care plan, no problem. But what it's really doing is saying, don't use a walker. Don't use a wheelchair. Don't walk the patient without anything. Use that. It's actually excluding everything that's not on the care plan. So you think that care plans are inclusionary when in reality, they're exclusionary. You're just going to focus on what they included. That's very complex. I get it. And I don't normally go into that because those of you who go on for nursing will learn that. Care plans are exclusionary by being inclusive. Okay. You're welcome. I know it's a little complex. So we're going to turn this patient. I'm running late again. I am always running late. I am time blind. All right. So when we're going to turn a patient, if they cannot turn themselves, and our care plan says he can't, we're going to position the body in such a way that makes the turn easy. Now, if I just walked up to this patient, if I was going to turn this patient and I just walked up to the patient, of course, I would use a privacy blanket. I'm just going to show you. And I scoot the patient toward me. All right, Miss Jones, scoot toward me. Yay. All right. Now, I'm going to roll this patient up. And she's pretty light. She's a mannequin. She doesn't really weigh much, right? But I would still kind of struggle a little bit. So if I'm just trying to roll her on her side and I'm doing this, right? See how she's sliding and she's not really cooperating and right, somebody's going to get hurt here. So what we're going to do is position the body to make it easy to turn. So it's no stress on her and no stress on me. If I just come over and try to roll her, I have a weight limit that I can effectively handle because she's not cooperating. But if I prepare her body for the turn, that weight limit increases to about 3 times my body weight. Okay. I can turn somebody that is way heavier than me as long as I position them properly first, with no stress on them or me. Because the whole point here is to get their body kind of leaning in that direction before I start the turn. And then it's just really easy to roll. And the way that we do that is using this. There's 4 steps to this. And it depends on what side you're turning the patient to. So where would we get that for the test? Care plan. So what does our care plan say? Left side. So I need to turn the patient onto their left side, which is this side. This side. That's her left, not my left, her left, this side. So I never want to turn a patient toward me. You guys remember that? So I would have to be on the other side of the bed to roll the patient away from me. Everybody with me so far? Because you got to be on the correct side of the bed for this to work. So the first thing you need to know is what side am I turning the patient onto? And then you need to be on the opposite side of the bed before we start this.
On the care plan specifically, they mentioned
direction, that's going to be toward relative to the patient, right?
Always the patient. Remember our saying, it's all about the patient. This is why. Everything is about the patient, not about you. Okay? So I would be on that side of the bed. Good so far. Everybody with me? All right. When I'm on that side of the bed, the furthest arm away from me, so I'm over here, the furthest arm away from me goes up. The closest arm closest to me goes over. So if I'm turning the patient on their left side, this is how they should look. If I'm turning the patient on their right side, I should be over here, furthest arm up, closest arm over. Good? So that's the top half. That's only half the body. We have to turn the whole body. So let's talk about the legs. So furthest arm up, closest arm over, closest knee bent at the knee. So I'm going to bend the knee and put the foot flat on the bed. Okay? Bend the knee, put the foot flat on the bed. So she's a mannequin. She doesn't do well. That's why this is done on a live person. But let me just show you. So we're going to bend the knee and put the foot flat. See, she doesn't bend, right? Put the foot flat on the bed. Humans tend to bend a lot better. Okay, so bend the knee, put the foot flat on the bed. The furthest leg, we're going to bend the knee but angle it out. So it should look like this. So furthest arm up, closest arm crosses, closest knee bends, furthest knee angles. When you do that, your patient is almost on their side just by moving those four extremities. It positions their weight almost on their side. So then you just put a hand on their shoulder, one on their hip, and just roll the torso. Super easy. Doesn't take a lot of force. If you expect to put a lot of force in here, you can roll that patient right off the bed. Does not take you're thinking about trying to move a body, right? So you're putting lots of force behind. It doesn't take force. Not if you prepare them properly. Good? Okay. I used to take care of bariatric patients before they had surgery. This is way back in the late 80s, early 90s, before, Dr. Now was on TV. I would go in and take care of patients before and immediately after surgery. And a lot of these patients are bed bound. When you get into 700-800 pounds, it's a lot of weight to try to lift to a standing position. So these patients, in a lot of cases, are bed bound. And I alone, and I am not super strong. I alone can turn somebody onto their side. That is a significant amount of weight as long as you prepare them properly first. This was in a home care setting. There wasn't anybody to help. Okay, good. Okay. So our care plan tells us to position the resident on his left side. Patient requires support to remain on his side and is unable to assist with turning. So we're going to follow that care plan. We're going to do our opening. Knock, knock, knock. Hi, Mr. Jones. My name is Patty. I'm your CNA today. I need to get you turned on your side. Is that okay? They're going to say yes. They always say yes because it's the test. They have a script. They're going to follow it. We're going to close curtain, wash our hands. After we wash our hands, we'll determine if we need gloves. Now, time out real quick. For the test, you would be the patient. You're fully clothed. And I'm assuming you're holding on to all of your own body fluids like a champ. So I'm not in danger of touching anything that I shouldn't be touching without gloves. For the test, that's your scenario. You don't need gloves for the test because your patient is fully clothed. You're not coming into contact with anything. Good? In a clinical setting, if you've got an immobile patient, they're not getting up to go to the bathroom. They're immobile. So you're probably going to encounter some sort of body fluids. Would you need gloves? Yes. It is not based on the skill. It's based on the patient you're doing the skill on. Their particular circumstances. Good. I'll give you another example. Let's say that we have a brand new mama. She just gave birth about 4 hours ago. She had an epidural. She still can't feel her legs. But she also is having some pretty significant bleeding and clotting. And she is at risk. And we want some what we call postural drainage. And you happen to work in the mother baby unit. And I ask you, hey, I need you to go turn the patient onto their left side for a little while. Now, this is a young person, and she's holding on to all of her own body fluids normally. She's a young mom. She's not incontinent normally. But right now, she can't feel anything below the waist. And she's got a bleeding issue. Would I need gloves?
Yes.
Even though she's a young woman, the circumstances are that I might come into contact with body fluids. Therefore, I would need gloves. Make sense? Good? All right. So decide if you need gloves. So we're going to use some supplies. So we always have to have a place to put them. We'll grab our barrier. We'll do that first, and then we'll go back and get our supplies. When you get those pillows, don't hold them up against your uniform. Linen rules.
How many do you need?
Look at the bottom of the page.
3?
How many does it say? Page 115? Is it 115?
Oh, 39.
139.
Oh, okay.
I'm sorry. Page 139, the bottom of the page. Right. I can answer that question for you, Nancy, right? I can answer that question for you, but it's much more impactful if you know where to get that information yourself. Okay.
What's a bath blanket?
A privacy blanket.
Oh, okay.
Privacy blankets and bath blankets are the exact same thing. Remember, in healthcare, everything gets at least 2 names. And if you ever are wondering, if you look at that and you think to yourself at home, you're reading this, you go, what's a bath blanket? If you go back, I think it's page 39 in your book. I think it's 39. Somebody look at page 39 and tell me. 37. There it is right there. 37. I knew it was 30 something. You can see what something is. There's the picture of it. It's the same picture, exact same picture as what you have in the supply pictures. So you can match them up and it'll tell you what that item is called, along with any alternative names it might have. I put a lot of thought into this book, guys. Yeah, every word in here I wrote. Every single word. Feel free to, yell at me in the middle of the night. I don't blame you. It's a lot of words. All right, so we're going to use a privacy blanket. When we use a privacy blanket, we put it on over the sheet, pull the sheet down underneath. Don't snap or shake your blanket, but we're going to use it to cover the patient and still allow us access to all of their body areas. When you get the pillows, don't hold them against your uniform because we don't hold anything against our uniform. Patient should always be in the middle of the bed, so we'll have the patient scoot toward us, prepare their body for turning, and then we can turn them. We're going to get 2 checkpoints for this. We're going to assist the patient with turning on the side before we put the pillows in place, so that just kind of makes sense. And we're going to keep the resident positioned a safe distance from the bed from the edge of the bed at all times. Those are your 2 checkpoints you're getting checked off for that action, just to have the patient scoot towards you and then roll them. Once we roll them, they have to be in the middle of the bed. Now, this is our checkpoint. Leave resident position on side with upper knee bent in front of the lower leg. That's our checkpoint. This is what we're going to get checked off. Do you guys remember when I said about the legs? You're going to bend one knee and put the foot flat on the bed and then angle the other one out. That's why we're doing those 2 steps. When we turn them, that knee that was bent, when it falls it will fall over beyond the knee that's angled. Okay. I always have a reason for every step. And this is why we want that checkpoint. You don't want those two knees right on top of each other. It's uncomfortable, but also it's pressure. Once we get the patient on their side, we're going to put a pillow behind their back in a roll. That just keeps gravity from pulling them onto their back. And then we're going to put a pillow between their legs, specifically between the knees and ankles. You want those two areas padded so that pillow will go lengthwise along their lower legs. You're going to put a pillow under that upper arm to get it into a neutral position. If you don't put that, if you turn the patient onto their left side, right, this arm, gravity pulls it down. It's going to put a lot of pressure along the upper neck and shoulder area right here. And that downward pressure of the arm can cause muscle spasms, headaches, and generalized discomfort. When you put a pillow under that arm, it relieves that pressure, puts that arm in a neutral position. So this is actually a pretty important pillow. If you go to bed at night, if you can get somebody to put a pillow behind your back and put a pillow under your arm, you will sleep like a baby because it's like an anti-gravity position. Everything is supported. But please make sure when you put this, you see how this pillow is angled? Don't angle it over their face. Be careful of that. And then once you get that pillow in place, you want to adjust the pillow that's under their head just to make sure it's not under that shoulder, right? That it's not pushing up. You want that pillow just under the head and neck, not the shoulder. And then we're going to put the call light directly in that bottom hand. You don't want the call light in the top hand because then it goes across, that cord goes across the neck. So by putting the call light in the bottom hand, that cord is not a choking or strangling position. Good. And then we'll do our closing. Thank you very much, Mr. Jones. Is there anything else I can get for you? And yes, we are going to offer a magazine. We know they're not going to take it. They're on their side. They're tucked in. They're not going to be flipping through a magazine, but we're still going to offer one. Would you like a magazine before I go? Bed's in the low position. Environment is clean. Your call light is in your hand. Open the curtain. Wash my hands. Review the care plan. Make sure I didn't miss anything. Care plan says left side. Are they on their left side? Yes, good. All right, I'm good. My skill is done.
When we're actually doing the test, do we narrate each thing that we're doing as we do it, or do they just observe it, us doing it?
You are not talking to the evaluator.
Okay.
That is not your role.
Okay.
The evaluator does not even exist in your world. Who does?
Care plan.
The patient. The patient exists in your world. Do you know who doesn't know what you're doing? The patient. Do you know who should know what you're doing? The patient. So should you narrate it? But not for the reason that you're thinking. Okay.
I've heard you end every skill by audibly saying, "This is the end of the skill." It's something you actually told me. You said, "I'm done with it."
So yes, this is the one thing that you have to do for the test. Okay. And that's because you can make corrections. So anytime during the skill, when you're in the middle of the skill, when you're at the end of the skill, it doesn't matter. If you realize you did something wrong, you can make a correction and you'll get credit for it. But you can only make a correction up until you end the skill. Because once you have ended the skill, what you're saying is, red buzzer, lock in final answer, I'm good. You can't go back and change anything then. So in a clinical setting, I'm not going to tell the patient my skill is done. This is the one thing that we're going to do for the test, but they're not going to let you go on to the next skill until you declare that the skill you just finished is done. They will actually, if you start to go into it, they'll say, stop, don't. You need to tell me when you're done with that skill. And they're pretty forceful about that. And you'll think, oh my God, I did something wrong. They're mad at me. They're not. They have to follow the rules. Okay. Good. Makes sense. And it's all about that correction thing.
So we do tell them that we're finished with the skill.
Yes.
Okay.
The eval, you will, that's the only, and you're not really talking to the eval. I still talk to the patient. My skill is done. Yeah. And in a clinical setting, I don't actually say my skill is done. I'll say, I'm going to leave now. But you got the call light if you need me. Otherwise, it's a little rude, right? I just got all up in her business. And I don't even say goodbye, right? That's a little rude. So I usually will at least announce that I'm leaving. Okay. Good? Questions? Let me show you this video and then we'll take our break. Actually, Jake's going to show you the video. I should give credit.
Thanks, Jake.
Got it. Hello.
Good morning, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. I need to turn you onto your left side and use some pillows to secure your position. Is that okay?
Yes.
Okay, I'm going to close the curtain, wash my hands, get my supplies, and I'll be right back. Now that I have clean hands, I'll get clean supplies. We're going to start with a barrier, and we'll place it on the overbed table. And this gives us a clean place to put our clean supplies. Now I'll get 3 pillows. And a privacy blanket. We'll bring this over to the side of the bed. Okay, Mr. Jones, I'm going to start with a privacy blanket. I'll place this on top of you to help protect your privacy and to keep you warm while we do this skill. So I'll take the privacy blanket and unfold it, being careful not to snap it or shake it. We'll lay it right over the patient on top of the sheet. Can you hold that for me? Thank you. I'm going to pull the sheet all the way down to the end of the bed. This just gets that sheet out of our way. Okay, Mr. Jones, can you scoot your body toward me? Thank you. Now I'm going to position you for the turn. So we're going to take the furthest arm and place it up over the head. The closest arm will cross the chest. The closest knee is going to bend with the foot flat on the bed. And then the furthest knee will angle out. Okay, just relax for me. Thank you. And now I'm going to roll you on your side on the count of 3. 1, 2, 3. So I'll roll the patient, maintaining a wide base of support. And then I'll use some pillows to keep him in this position. So the first pillow will go behind the back. We're going to move the privacy blanket out of our way so we don't tuck it in. The first pillow will go behind the back. We're going to tuck this edge underneath the patient. So I'm going to tuck down and under. This edge will roll up and then under the patient, down and under. And that provides a nice roll. We'll go to the other side of the bed. So this pillow will go between the legs, specifically between the knees and the ankles. We don't want the legs to lay right on top of each other, so I'm going to move the top leg just a little bit forward, and then I'll lift from below and place the pillow in between the legs. That way they're not laying right on top of each other, and the bony prominences are separated by the pillow. I'll cover the patient up. I'm going to take the third pillow, and this one will go underneath this top arm. As the arm droops down, this puts a lot of pressure along the upper back and into the neck. We need that arm in a neutral position. So I'll take the pillow, lift the arm from below, and place the pillow right under the elbow area of that top arm. Now the pillow under the head is under the bottom shoulder. So we're going to lift the head up, move the pillow so that it's only supporting the head and neck, and then we'll place that bottom arm underneath the pillow. We're going to take the call light and place it directly in that bottom hand. Okay, Mr. Jones, I'm going to remove the blanket and pull the sheet up now. So we'll pull the sheet right up over the blanket and the pillows, and then remove that privacy blanket, rolling it into a ball as we remove it so that trailing edges don't contaminate other surfaces. We'll adjust the sheet for neatness and appearance. And we'll open the privacy curtain. Mr. Jones, are you comfortable?
Yes.
Okay, I'm going to go dispose of my linens and I'll be right back. This will go into dirty linen. We'll dispose of the barrier in the trash can. And we'll move the tray table back to storage. Okay, Mr. Jones, is there anything else I can get for you while I'm here?
No, thank you.
Are you comfortable?
Yes.
Okay. Is the head of the bed, does it need to be adjusted at all?
No, thank you.
Your environment is clean. Bed is in the low position. I'm going to go wash my hands. After washing my hands, I'll review the care plan, make any corrections, and tell the evaluator my skill is done. Yes.
So, not to like sound sassy, but if they're already covered with a sheet, why would we get a private?
So you don't need, you actually don't need one. You can do this with the sheet, but the problem is that you're going to run into is that it's hard to get the pillow between their legs with a sheet covering them. So yes, you could absolutely, as long as they're covered, I don't care how they're covered. I just don't want to see their knobby knees. But what you're going to find is that you're probably going to have to untuck the sheet to have access to their feet, and then you're going to have to retuck it. And a lot of people find hospital corners much harder than working with a privacy blanket. So however you want to do it is fine. Like I said, there's a million ways to do these skills. If you want to do it without a privacy blanket, that's fine. It's for continuity's sake. Anytime the patient's uncovered or undressed, I just advise a privacy blanket. That way it's only one rule you have to remember. Okay. But yeah, you can do this either way.
So in this case, you can stand and like when you're positioning the pillows, you're okay to stand in front of them, like on their side.
Yeah, that's fine. That's fine. You just don't want to be like, you don't want to turn them towards you, and you don't want to be like front and center.
Back all the way to glove rules. When it says personal skin, does that mean like their private area?
Yeah, personal skin is anything normally covered by a bathing suit.
Okay.
That's a good way to remember personal skin.
Okay. Thank you.
Yeah.
Been stuck on it.
Yeah. Yes, I do know that there are some very unusual bathing suits out there. I'm just talking about a normal high school level bathing suit. Okay. All right. Any questions on this one? Any questions on this one? Okay, let's go ahead and take our break. Come back in 15 minutes. We'll get to another skill. care.
Can I ask a question right quick?
Sure.
Can we buy those totes from you? The CNA totes?
Are you talking about the practice kits?
Like one of those bags up
Yep.
there?
So that's a practice kit.
Uh-huh.
It comes in a bag, but it has everything you need to practice. It has a bedpan, a bath basin, an emesis basin, orange stick, emery board, toothbrush, toothets, denture brush, denture kit, denture practice thing, chucks, gloves, drainage bag, triangular graduate container, and bath blanket.
How much does that cost?
$49.99
Is that all?
for you guys. Yeah, for you guys.
That's
Online, if you order it virtually, if you guys order, I think it's $67.99, I think.
$4.99.
64. Yeah, $64.99. For you guys, I give you a break. So it's $50. All right. So yeah, if
Take
you
credit cards?
yes, if you want one, just see Jake and he'll get you all squared away. All right. Oh, Peyton. I knew I got on here for something. Got it. Okay. All right. Any questions? Moving on. Okay. Foot care is our next skill. You already know how to do this. It's just like hand and nail care, just a little bit lower, and we don't do anything with toenails. You already know how to do this. So if you look at this page, the overview page, you can see all of the principles that are involved. They're all spelled out for us here.
What page are you on?
118.
Oh,
We're going to follow the care plan. We're going to do our opening. We will use gloves for this skill because the reason that we're doing this skill is to look for abnormalities. Since we don't know if there are any, there's a potential for non-intact skin. So we will wear gloves for this. We're going to use a barrier, but this time we'll put it on the floor because that's where we're working. Linen rules apply. Washing rules apply. And we're going to clean the basin the same way we clean all other basins. We'll do our closing the exact same way. Down here is your test information. Somebody with your level of experience should be able to do this skill in 13 minutes or less.
do it 1 foot at a time.
We're going to read the care plan. This is going to be a live testing student skill. That means one of you guys might be a patient for foot care. I know, and I get that reaction all the time. Like, I don't like anybody touching my feet. Unfortunately, for the test, if your partner gets a skill, you will have to let them wash your feet. But guys, this isn't it's not like a pedicure where you're, soaking the foot in bubbles and you're going to scrape the heel and you're going to trim the toe. It's nothing like that. We put the foot in the basin, we take it out, we wash it. We put it back to rinse, we take it out to dry. We put lotion on it and we look. That's it. That's the whole skill. It's super easy. It shouldn't affect you too much, even if you're ticklish, because they're not doing ticklish type of stuff. I am probably the most ticklish person in the world with my feet. So I get it, but just go to your happy place. Do what you got to do. Okay. This person will be sitting in a chair at the beginning of the skill. Charting is not required. So if we look at the top page 119, it gives us our care plan. Step-by-step instructions. Our supplies are along the bottom. But let's look at this care plan. It says to provide foot care to 1 foot using soap and water. What are we using? Why? Care plan said, absolutely, absolutely. The resident is sitting in a chair and their sock and shoes should be replaced at the end of the skill. This last sentence is for the test. It's for the test. And let me explain why. Remember, the evaluators have to follow the care plan too, right? Okay. So it says specifically the patient or the resident is sitting in a chair. So the evaluators are going to make sure that that patient is sitting in a chair at the beginning of the skill. They're not going to have you get the patient out of bed and into a chair. Nothing like that. They're already in a chair. Remember, the evaluators have to follow this, just like you do. Good? But it also says that their sock and shoe should be replaced at the end of the skill. Now, this is very specific for a reason. When you are testing, are you planning on taking an extra set of socks with you? Probably not. You don't have a set of socks in your back pocket just waiting for the opportunity to slip them on. So that means that you've only got the socks you wore to the testing center. The testing center does not have extra socks that they give out. Normally, when you wash feet, you put clean socks on out there in the real world. We don't have clean socks for the test. So at the end of the test, unless we have something that tells you what to do, you're going to stand there and look at us and go, what do I do? There's no clean socks. So that's why this is here. It says the sock and shoes should be replaced at the end of the skill. It's telling you, yeah, we know those aren't clean socks. Put them on anyway. Follow the care plan. Got it? All right, so now we're going to learn the skill-specific steps. This is an easy skill, unless you have trouble getting on the floor like me. I hate this skill because I don't get up from the floor very well anymore. So this is kind of a hard one for me. But overall, the skill itself is pretty easy. It's a lot like hand and nail care. Let me show you just how much it's like hand and nail care. So first we're going to do our opening, or we're going to read our care plan. That told us what to do. And then we're going to do our opening. Knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to do foot care. Is that okay? And the patient's going to say yes because they're following a script and they're always going to be compliant. And if they're not compliant in the real world, what do? Tell the nurse. We already know what to do with that. We're going to close curtain, wash our hands, and then we're going to get our barrier. In this case, our barrier is going to go on the floor because that's where we're working. So we'll get the barrier, put it on the floor. We're going to go back and get the rest of our supplies, which is 2 washcloths, a towel, basin, soap, lotion, gloves, and we'll put those on the barrier as well. If you want to put an extra towel down for you to kneel on, that's fine. If you want a barrier to kneel on, that's fine. Nobody cares, but it's not required because remember, your uniform is not clean once you start work anyway. Okay, good. Are you starting to see that a lot of this stuff that we learned last week just keeps coming up over and over and over again?
He has his feet on a chuck. Is that what we're going to do? Have his feet on a chuck?
Right.
Okay.
Right. Should we ever have bare feet on a bare floor?
No.
No. So we want to put the barrier in place before we take his socks and shoes off. Okay, good.
So would that be 2 chucks? One for the supplies and one for his feet?
We're going to put the supplies right on the barrier.
Okay.
Okay. So we're going to go get our supplies. Don't hold them against our uniform. And we're going to put those supplies directly on that barrier that we're working on. If they've got big feet and you're running out of room, go get a second barrier. Nobody cares. Okay. So we're going to follow our washing rules. Whatever we wash, we rinse. Whatever we rinse, we dry. We get a paper towel to turn the water on. We check it. Who checks it? The patient checks it. If the water gets cold or soapy, should we change it? Okay. All of those rules. We know those rules. Nothing new to learn there. Like I said, you already know how to do this skill. Good. Okay. We're going to clean the basin the way we clean every basin. We're going to rinse it. We're going to dry it. We're going to put it away. Just like we do every basin. Make sense? So let's get into our skill-specific steps because we know all of those. We just went through all those. We know all of those. Now let's get into our skill-specific steps. So this is specific to foot care. Doesn't really apply to any other skill. It's only for foot care. We're going to soak the foot in the basin of water on the barrier. Put the foot in the basin. Now, in a clinical setting, I'm probably going to leave the patient to soak a little bit. Okay, I'm going to get them soaking. I'm going to wash my hands. I'm going to go take care of something else. And then I'll come back 5 to 10 minutes later and I can finish the skill. But for the test, we don't have anywhere else to go. We have no other patients. So for the test, we're simply going to put the foot in the basin and keep going. Okay, good. All right. So put the foot in the basin. We're going to take it out of the basin, supporting it from below, and put it on a towel beside the basin to wash it, because we don't put soap in the basin. So we'll get our washcloth. We're going to wring it out really well. We'll put soap on the washcloth, and we're going to wash all surfaces, whatever's there, whatever you see. Once you, once you've washed the foot, we're going to put it back in the basin to rinse the foot. And then once we rinse the foot, we're going to take it out of the basin to dry the foot. So this is just like hand and nail care. We put the hand in, we took it out to wash. We put it in to rinse, we took it out to dry. Same thing with the foot.
Don't the towel have soap on it because you clean the foot on the towel?
Remember that it's very little soap. You wring the washcloth out, put a little bit of soap. It should stay on the washcloth, not really on the towel. And when I do this, you're going to see that I fold the towel. So they put their foot on the top. When I put it into rinse, I unfold the towel, and now I put their foot and dry it off. But it doesn't matter. What I'm trying to say is the test doesn't care. You're not using that much soap. Okay. Once you're, you have your foot dry, we're going to lotion all surfaces, but no lotion between the toes. Lotion holds in moisture, and between the toes predisposes us to athlete's foot because it's warm, dark, moist. Is it okay? Okay. All right. The whole purpose for you doing this, though, is to look at the foot. That is the whole reason you're there. It is not to clean the foot. Cleaning the foot is just gets us access to. That's because feet are usually covered in shoes and socks. We don't see them. There could be a wound on there that we know nothing about. So the whole purpose of doing this once a week is to look at the foot, just to make sure there's nothing there. And you guys are young. You're bendy. You're bendy. We're not so bendy when we get old. You can put your foot up just like this and look at the bottom of it. No problem, right? You are bendy. When we get less bendy, you may not even see your feet anymore. It's like, yeah, they might be down south somewhere, but I haven't seen them in years. Don't know where they are. They're off doing their own thing. Well, somebody's got to be looking at the feet. That's why we do this. Good? All right. So we want to make sure that the foot stays on the barrier, not on the bare floor. Bare feet should never touch a bare floor. So make sure that when you're moving this foot around, you're not placing it on the bare floor. We're going to put the sock back on, smoothing out any wrinkles. We know wrinkles are bad. And then once we get the sock on and everything, you know, we're all done, we'll put the shoe on and clean up. Now, you can clean up before you put the shoe on. I don't care. Nobody cares. Knock yourself out. If you want to put the sock and the shoe on before you start your cleaning, that's fine too. However you want to do this, there's no checkpoint for it. Just make sure at the end of the skill, your patient is sitting in the chair. They've got a shoe on, a sock. They got a sock on and a shoe on, and their environment is clean. How you do that? Completely up to you. Okay? Finish up with your closing. Thank you very much, Mr. Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine before I go? Environment's clean. Bed's in the low position. Here's your call light. If you need anything at all, let me know. Open the curtain. Wash my hands. Think about my skill. Check the care plan again, just in case. And then tell the evaluator my skill is done. Now, to answer your question, our care plan told us to do how many feet? 1. So for the test, we're only doing 1. If the patient has 2, you can do 2. Doesn't matter how you do them. Do them both at one time. I don't care. Put them both in the basin if they'll fit. If they won't fit, do them one at a time. Nobody cares. If somebody does care, they would have specific instructions on how they want you to do that. Where would we find those instructions? On the care plan. Good?
So this closing part, that's for the chair.
We're leaving them on the chair, but we still go through all of the
Your
points
call
of
light,
it.
Your bed is in a low position.
So the reason that you want and no, there's no checkpoint for bed in the low position, but you should still check. And the reason you should still check is because we're leaving the patient in a chair. Is there a possibility that they may want to get up out of the chair and back into bed at some point without us being in the room? And if that bed is not in the low position, they may have trouble getting into it, and now that's a fall risk. So anytime you leave the bedside, whether it's a checkpoint or not, I don't care if it's on the checklist or not, anytime you leave a patient, that bed needs to be in the low position. Okay, does that kind of make sense to you?
Yeah, and for the sake of the test, with the call light, you just mention where it's located. You don't actually.
It's got to be within reach. That's the checkpoint is within reach, because when you leave the room, they've got to have a way of calling you if they need to. So for this skill, your patient's going to be in a chair. The chair is going to be right next to the bed.
Okay.
Yeah, it won't be across the room. It'll be right next to the bed. So just lay the call light on the bed next to the patient, or you can actually hand the call light to the patient. Here you go. Okay, good. Okay. Remember, this care plan is only for this patient. That's it. This patient, not this one. This one would get a different foot care plan because they got other things going on. This one would get a different foot care plan because they got other things going on. This care plan is written with this one patient in mind. So a question comes up, well, what if they can't sit in a chair? Well, your care plan would tell you what to do. I don't know. I don't have that patient. Never met that patient. I don't know what to tell you to do with that patient. Do you know who has met that patient? The nurse. So who's your best source of information for that patient? The nurse. Don't ask me. That'd be like asking me for stock tips. I don't know. Nancy Pelosi's your girl. Okay. Yeah. Good. Makes sense? This care plan for this patient and this patient only. I know this patient. I wrote her care plan. I can answer questions on this patient. I can't answer questions on this one or this one. I don't know. Go to the person that does. Good? Okay. All right, let's watch the video. We're going to get through 2 more skills after this very quickly. And then we're going to get into, because they're all like this. You already know. You already know 90% of the skill. We're just going to go over the part you need to know moving forward. We're going to go through those 2 skills super quick, and then we're going to get into test registration. Okay? I got it. No, you got it. Yeah. Hello, good afternoon, Mr. Jones. My name is Patty, and I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. I'd like to perform foot care on your right foot per the care plan. Is that okay?
Yes.
Let me close your privacy curtain, wash my hands, and get my supplies, and I'll be right back. After washing my hands, we'll gather our supplies. We're going to start with a barrier on the floor under the patient's feet. So we'll spread the barrier out. And can you move your left foot to the side, please? Thank you. I'm just going to place this barrier on the floor. If you can lift your foot. Thank you very much. And we'll move that shoe out of the way. We'll also need a basin, soap, and lotion. Once the barrier is in place, we're going to get 1 towel and 2 washcloths and take them to the patient's area. You can place a barrier on the floor to kneel on, but this is optional. All right, Mr. Jones, I'm going to go get some water in the basin. I'm going to use a paper towel to turn the water on. Check the water temperature with the inside of my wrist. It should feel warm, not hot or cold, just warm. And we'll fill the basin about 1/4 of the way full. And then throw the paper towel away. Mr. Jones, would you like to check the water temperature?
Oh, that's beautiful.
Very good. I'm going to set this down. For this skill, I need 1 set of gloves. I'm going to go ahead and put my gloves on before we get started. And then I can take your sock off. We're just going to lift your foot and remove your sock. We'll set your sock to the side, being careful not to overextend, and place your foot into the basin. After your foot has soaked for a few moments, I'll place the washcloths in the basin and rinse your foot, and then lift the foot out and place it on the towel, wringing out one of the washcloths and applying soap. We'll apply soap to the top leaf and then wash all surfaces with short, soft strokes or a patting motion. We're going to wash down each one of the toes and then get in between the toes. And then gently we'll lift the foot with support and inspect the bottom of the foot while we wash all areas from top to bottom. And then we'll set this washcloth aside and place the foot back in the basin to rinse. We'll use the second washcloth to rinse the foot, squeezing the water to make sure that the foot has been rinsed well. I'm going to unfold the towel and lift the foot and place it on the towel to dry. We'll blot the foot dry around the ankle, the top of the foot, the heel of the foot, and then we'll lift the foot gently to dry the bottom. We'll take an edge of the towel and slide it gently in between each toe to blot to make sure no moisture remains behind. Now that the foot is dry, we'll get some lotion, warm it up in our hands, and then apply it to all areas of the foot except between the toes. So the top of the foot, the heel of the foot, and the sole of the foot, but not between the toes. And then we'll wipe off the excess lotion. The care plan has told us to replace the patient's sock. So once the lotion has been removed, I'll take the sock, make sure it's right side out, and scrunch it all the way up to the toe seam. We'll put the sock over the foot, making sure the toe seam lines up across the toes, and then we'll secure the sock over the heel, minimizing wrinkles and making sure the sock fits appropriately. And then we can gather our dirty linens and place them in the soiled linen hamper. So we'll place our soiled linens in the soiled linen hamper. Now we can clean our basin. I'll bring the basin to the sink. We will dispose of the water in the sink, rinse the basin, and then dispose of the rinse water in the sink as well. I'm going to set the basin down, disinfect it per facility policy, and then use a paper towel to pick it up. We'll dry the inside with a paper towel. Throw that paper towel away. Dry the outside with a paper towel and throw that paper towel away. And then get one more for the drawer. After cleaning the basin, we'll use the paper towel to pick up the soap and the lotion and return the basin to storage. We're going to put our supplies away by opening the drawer with a paper towel. We're going to put the basin, soap, and lotion in the drawer, close the drawer with a paper towel, and then we'll throw the paper towels away. And then we'll remove our gloves, being careful not to contaminate our hands. So now I'm going to gather the barrier, and we'll throw this away. And I'll help you put your shoe back on. There you go. Are you comfortable?
Yes.
Is there anything else I can get for you while I'm here?
No, thank you.
Would you like a magazine before I go?
No, thank you.
Your environment is clean. I'm going to go open the curtain and give you your call light.
Thank you.
Okay, Mr. Jones, here's your call light. If you should need anything at all, just press that red button. I'll be happy to come back and help you.
Thank you.
Is there anything else I can get for you before I wash my hands?
No, thank you.
Okay, have a great day. I'm going to go wash my hands. After washing my hands, I'll review the care plan, make any corrections, and tell the evaluator my skill is done. Questions?
So this doesn't really with foot care, but with washing your hands, do you have to use 2 separate paper towels for each hand? Like, do you have to use a different one for?
Use as many paper towels as you need to. If you've got big hands, you might need 4. If you got little hands, 1 might work, but you just want to make sure that you dry. And for me, I need 2, you know, to dry effectively. Sometimes I'll use 3, depending.
This is an old question, but when we're dressing them, on the sleeve of the shirt, do we scrunch that up also?
You scrunch up the sleeve and put your hand in through backwards, holding their hand like you're shaking hands. Slide the sleeve over yours and then theirs.
Thank you.
That keeps their fingers from bending backwards. Good. Ready to go on? You guys all know how to do this. Mouth care. I'm guessing you've probably brushed your teeth before. Probably even this week. Maybe. You know how to do this. There's nothing strange, unusual, weird that you have to learn here. You're brushing teeth. Now, because we are brushing teeth on somebody else, we do have to think about safety because you automatically go to the sink to brush your teeth. You're standing upright, you know. You don't really think about it. It's part of your routine. If somebody's laying down, now we got to think about safety with mouth care. Page 92 gives us all of our overview for this particular skill. The principles are outlined here and they're specified here. Down here is your test-specific information. Somebody with your level of experience should be able to perform this skill in 12 minutes or less. They're giving you 12 minutes to brush teeth. 12. Yeah, so even if you think about wetting the toothbrush, putting some toothpaste on it, drying off, right? You know, it doesn't take 12 minutes. Don't rush this, guys. And they're not even grading you on how long you brush for. You don't have to set a timer and brush for 2 whole minutes like the dentists tell you to. They aren't timing you. Just get all the surfaces, top, bottom, front, back. Just get it all done. Nobody cares how long it takes. Just get it done. So 12 minutes? Man, that's way more time than you need. Slow down on this skill because you're going to have a tendency to rush through it. Get it done. Nobody wants you in their mouth. It's a live patient skill. You don't want anybody in your mouth. I get it. I do. But for the test, go to your happy place. You may be a patient for this.
Ruining someone's day if they have to brush my teeth with braces.
So you're going to, during the when the I can't talk. At the beginning of the test, when the evaluators check you in, they're going to ask you, do you have any conditions that would prevent you from being a patient for any skill? You are going to want to say, yeah, I've got braces. If you've had recent dental surgery, if you've had a tooth pulled, if something like that, you would want to let them know that. Other than that, try not to make it hard on the evaluators to pair you up with somebody. Okay. But yeah, you've got to get out of mouth care free card there. Yeah, if you've got braces. Yeah.
What about dentures?
Let them know, let the evaluator know that I've got dentures and they won't use you for this skill. Not unless they absolutely have to. Now, there are situations that, if everybody else is not a candidate, it might be you. Or if you and one other person are the only ones that show up to test that day. That has happened. It's rare, but it has happened. If there's only 2 of you to test, guess what? You are the patient for anything they got to do. Doesn't matter whether you're a good fit or not. You are now, congratulations, the patient. You okay? Ow. All right. Remember that they're not timing you on the actual teeth brushing. Page 93 gives us our step-by-step instructions. The care plan is at the top of the page. Your supplies are at the bottom. You need to learn your supplies. Flashcards are your friend. Here's our care plan. Resident with natural teeth, their own teeth, real teeth, is lying in bed and needs mouth care. Somebody is going to ask, wait, Miss Patty, what if they have dentures? And I'm going to tell you, stay tuned until next week. We have a whole skill for that. The resident is not able to provide their own mouth care. That's it. They're not able to do it themselves. Don't make them something they're not. Don't put into your head that they are paralyzed, that they have a swallowing problem, that, you can make this patient anything you want to, but that doesn't make it real. It just says they can't brush their own teeth. So what if it's you? What if it's you? If you go out this weekend and you got a group of friends and you head out into the woods with some pickup trucks and you have a couple and somebody says, I bet you $10 you won't go over there and grab that porcupine. And you think, I could use $10 and you've got some liquid courage on board. You might just march over there and grab that porcupine. And now you got all kinds of porcupine quills in your hands. Are you going to be able to brush your teeth? No. By the way, that was a real event that actually did happen. And that person needed a little help brushing their teeth, along with everything else. Okay. Do not assume, based on a care plan, that you know what the patient is. Good. Good. All we're going to do is this. Doesn't matter what the patient looks like, how old they are. We're just going to do this. All right. So let's look at some skill-specific steps since we know everything else. We know that we're going to follow the care plan. We know to do the opening. We know to wear gloves. It's body fluids. We know to use a barrier on the table. We know not to hold stuff against our uniform. We know how to clean the basin. There is nothing new here to show you. You know all of that. And by now you should be rolling your eyes. Okay. So let's look at our skill-specific steps. For this skill, we're going to brush somebody's teeth, but they're laying down in bed. What position should they be in? Get them sitting up. Put the head of the bed up. For the test, it doesn't matter when you do that. They don't care. They do not care. They do not care. You are not being graded on infection control when you put this bed up, but I want you to think about it. You're going to put your hands in somebody's mouth. I would prefer that they're somewhat clean, right? So we can't touch the patient until our hands are clean. We know that's a rule. That's a cardinal rule. We can't ever break that. That is set in stone. Can't touch the patient until our hands are clean. If you put the head of the bed up, that pillow that's behind their head is going to push it forward. It's not a safe position for mouth care. We need to get that patient leaning forward and put the pillow down behind their back. or take the pillow away. Either way is fine. Behind the back is better. But now you're touching the patient. So remember our rules. Can't touch a patient until your hands are clean. So you could put the head of the bed up, go wash your hands, and then slide the pillow down. Perfectly okay. Knock yourself out. I don't care. They don't care. Solves the problem. Or you could wash your hand, do your opening, wash your hands, and then put the head of the bed up. But that bed controller, we know, is not always clean. Everybody's touched it. So what could we use between our clean hands and the dirty bed controller? Paper towel is the best option. You could put on a set of gloves, sure, but are you going to put those gloves in the patient's mouth? Why? Yeah, because they're dirty. They touch the bed controller, and the first thing our gloves should touch is the patient. You start to see how we can start applying these rules to every situation that we come in contact with, and it's going to answer all of our problems forever. All you got to do is learn what's on the back wall, and you will never have a question about how to do a skill, ever, because they're all covered. Make sense? Okay. So if you have clean hands and you're going to touch a dirty controller, you need something between your clean hands and the controller. Should you ever touch the patient before your hands are clean? So use those two rules to figure out how you want to do this. Okay? Make sense? Those are your two rules you have to go by. Don't touch the patient until your hands are clean, and don't touch the bed controller after your hands are clean. So use a paper towel. All right. The way that I'm going to show you, page 93, your step-by-step instructions, step number 7 shows you that I'm going to do my opening, wash my hands, and then take a paper towel to put the head of the bed up. That's how I'm going to show you. That's what's in your book. It checks off all of the checkpoints you need. You don't have to think about it. Follow the instructions. But if you see somebody doing it a different way, doesn't necessarily mean they're wrong as long as they abide by those two rules. You're looking at me. Are you confused?
I'm just trying to figure out setting the bed up.
Okay, so we have
and
two
getting
rules.
Your barrier and everything. Do you do that?
We have two rules. Two rules. First rule is don't touch patient until your hands are clean. That's a rule. Can't ever break that rule. Second rule is we don't want to touch that bed controller with clean hands before we touch the patient. So we're going to use a paper towel. The supplies doesn't enter into it. Remember, supplies, you have to have clean hands to get your supplies. So you would do that before you put the head of the bed up, after you put the head of the bed up. Nobody cares as long as you have clean hands to get your clean supplies. And your hands are still clean because you used a paper towel. Okay, good? Good, all right. Okay, we need to put a towel over the patient's chest. That's going to help keep that toothpaste from dripping all over their clothes, and it gives us something to dry their mouth with after we're done. So towel over the chest. We're going to wet the toothbrush and then put toothpaste on it. Don't put toothpaste on a dry toothbrush. It doesn't spread in the mouth very well. Wet the toothbrush first, put toothpaste on it, and then brush. Brush. This is your checkpoint, right? We're doing mouth care. You guys think that they're checking you off on all kinds of stuff with mouth care. No, it's just one checkpoint. One out of that whole one. It says brush sides and biting surfaces of teeth and gum line with a gentle motion. Does it tell you how long? No. Does it tell you to do the top first? The bottom first? There's no instructions here. It just says brush. Don't overcomplicate this, guys.
I would like to overcomplicate it with your experience. What do you think is like the most easiest or motions you want to do that you find, most?
For me, you're going to see me do it on this video. For me, I start on the top. I do the back on the top, the back on the bottom, and then come toward the front and do one side and the other, top and bottom, and then finish with the tongue. Okay. So if I'm on this side, I'll do the top first, then the bottom. Come over here, top first, then bottom, and then
And brush the tongue?
brush the tip of the tongue.
Okay.
Don't go far
Okay.
back because you'll find you will find their gag reflex. So just tip of the tongue. Okay. Then we're going to let them rinse. Here's a tip. Only use a pea-sized amount of toothpaste. That's all you need. That if you read a toothpaste box, it will tell you a pea size is all you need. Now, the commercials don't show a pea size though, do they? The commercials always show this big, swirly, like really, oh, it's pretty. It's stylistic, right? It does this whole swirl thing, right? Do you know why they do that on commercials? Money, 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 money. If they can convince you that this is the right way to do stuff and you use a ton of toothpaste every time you brush your teeth and all of it goes down the sink, you're going to buy more toothpaste. Yeah, absolutely. But if you read the instructions, it says pea size amount. Now I'm going to tell you, the more toothpaste you use, the more you're going to have to rinse. And your patient is not at the sink. You're going to have to do this, right? So you're going to be standing there for like 5 minutes giving them water to rinse with. You might have to go refill the cup because you ran out of water because you used too much toothpaste and they got it all caked up in their mouth. Ew. Pea-sized amount, all you need. Okay, let them rinse and spit as often as they need to. Once they're done, dry them off. This is the number one step that gets missed on mouth care. People forget to dry the patient's mouth. Don't leave them a drippy, wet mess. Look at your patient. Once you've got them all dried off, you can clean up, right? We clean our basin, put it away, put our towels in dirty linen, get rid of our barrier, remove our gloves, do our closing, and we're done. That's it. Question I get asked a lot. Do I have to brush everybody's teeth? No. If somebody can brush their own teeth, they're going to. I guarantee it. Nobody wants a stranger in their mouth. Nobody. Nobody. If somebody can do this on their own, they will. They will figure it out. And I've seen some really creative ways that patients have figured this out so that somebody else doesn't have to brush their teeth. But if your care plan tells you to, do a good job. Okay, good. You also want to try to normalize this for the patient. If you walk in there and you're like, I got to brush your teeth, and you're like, your patient is absolutely going to react to that. And they're going to refuse to let you do those skills. If it needs to be done, do it professionally. Do it right. Do it with kindness. Okay? And competence. All right. Remember, this care plan is only for this patient. This one can probably brush his own teeth. He doesn't need our help. This one probably just needs us to squeeze the toothpaste because she's got rheumatoid arthritis and can't squeeze toothpaste, but she can do the brushing motion. Every patient's a little different with what they need. How do I know what this patient needs? The care plan. Good? You're starting to click that together. My students don't fail skills. You don't. You don't. And the reason you don't fail skills is because of all this stuff I keep going over and over and over and over and over and over because it's important, but it's also what you're being tested on. Follow the care plan. Don't add to it. Don't take away from it. Don't make the patient into something they're not. Just do what it tells you to do. Good? All right. Show you the video. Mouth care. Good morning, Mr. Jones. How are you?
I'm well. How are you?
Fantastic. I'd like to perform mouth care on you. Is that okay?
Yes.
I'm going to close the curtain, wash my hands, get my supplies, and I'll be right back. I'm going to use a paper towel as a barrier to put the head of the bed up, since my hands are clean and the bed controller is not. Once we get the patient to an upright sitting position, I can throw the barrier away and then adjust the pillow so it's a little more behind his back rather than his head. There we go. Good?
Yes.
Okay, let me go get the rest of my supplies and I'll be right back. I'll gather my supplies. We're going to start with a barrier, and that gives us a clean place to place our clean supplies. So we're going to open the barrier up. And I also need a towel. We're going to get an emesis basin, a toothbrush, toothpaste, and a cup of water. And we also need a pair of gloves. I'm going to get my toothbrush prepared by wetting it and putting toothpaste on, and then storing it in the emesis basin until I'm ready to use it. Mr. Jones, can I place this towel over your chest?
Yes, please.
Thank you. This is just going to help keep your clothing clean. I'll put my gloves on. And now we're ready to brush your teeth. I'm going to brush the top, the bottom, the front, the back, and your tongue. So can you open wide for me? I'll start in the back, on the top, both sides. And then the bottom, both sides. The front, both top and bottom. And can you bring your teeth together? Thank you very much. And then stick your tongue out. Thank you. I'll set this aside, and now we can rinse. Go ahead and take a sip. Another sip.
Yes, please.
Okay. I'll pour the water in the emesis basin, set them on the table, and then I'll take this towel away and put it in dirty linen. I'm going to go clean my basin. We'll clean the emesis basin by dumping the saliva into the sink, rinsing the basin, setting it down, and disinfecting per facility policy. Then we'll take a paper towel to pick it up, a paper towel to dry the inside. We'll throw that paper towel away. Paper towel to dry the outside, throw that paper towel away, and one for the drawer. Now I can return the basin to storage, putting the toothpaste in the basin and using a paper towel to open the drawer to store the basin back in it. We'll close the drawer with a paper towel and then throw those paper towels away. All of these disposables will be disposed of. I'm going to go throw this away. I'll be right back.
Okay.
Now I can remove my gloves. Okay, Mr. Jones, is there anything else I can get for you while I'm here?
No, thank you.
Are you comfortable?
Yes.
Okay. Bed is in the low position. Your environment is clean. Let me get your call light for you. Would you like a magazine before I go?
No, thank you.
Okay. Here's your call light. If you need anything at all, just press that red button. We'll be happy to come in and help. I'm going to go open your curtain and wash my hands. After washing my hands, I'll review the care plan, make any corrections, and then tell the evaluator my skill is done. There's 11 here right now, Jake. All right. So another question I get asked quite a bit on that particular skill is, do you throw the toothbrush away every time? And the answer is, well, it depends. You probably don't throw your toothbrush away every time. So if it's a place that the patient is living, no, we're not going to throw it away. But if the patient won't be there tomorrow, you know, if it's a hospital or a short-term setting, then yes, you would. For the test, your patient won't be there in like 15 minutes. So you want to throw it away. Please, for the test, do not put a used toothbrush in the drawer. Okay, you guys understand why? Yeah. All right. Any other questions on mouth care? Pretty easy, right? All right, let's move on to respirations. Respirations is the act of breathing, counting somebody's breathing. You cannot tell somebody you're counting their breathing. If you tell someone, hey, I'm going to count your breathing, ready, set, go. Yeah, they either start breathing fast because now they're aware of it, or a lot of people will just hold their breath, you know, because they don't know what to do. You've kind of surprised them. So that's not going to get us an accurate reading either way. So we don't tell somebody we're counting their breathing. We tell them we're taking their vital signs. You also don't want to stand over somebody. This is creepy. It's creepy to stand over somebody not talking and stare at their chest. It's weird. And your patient will get anxious, and that's going to elevate their breathing, and we're not going to get an accurate reading. So for this skill, it actually looks like we're taking their pulse. We hold their wrist like we were taking their pulse. Don't find their pulse. You don't need to. We're not counting it. We're basically holding their hand, you know, like this. I don't have the pulse. I'm holding their hand, but she doesn't know that. She thinks I'm taking her pulse. Her focus is going to be here, not here. You guys understand why? It's just creepy to stand and stare. All right. So if you look at the overview on page 54, there's not many principles involved in this. We're going to read the care plan. We're going to do our opening. We'll decide if we need gloves based on this particular patient, and we're going to do the closing. There's nothing new to learn there. We've got those down pat. So let's look at our skill-specific steps. Page 55 gives you your step-by-step instructions, care plans at the top, supplies are at the bottom, and here's our care plan. So this patient will be laying in bed for this skill. Count the patient's respirations for 1 full minute and record our readings. Okay, that's it. That's all we're doing. That is a tested skill. Yep. Remember, you will get a documentation skill. You're going to get, everybody gets 1 documentation skill. The documentation skills were pulse, respiration, feeding, which we're going to go over next week, and drainage bag, which we'll go over the following week. So you're going to get one of those 4. This one, respirations, is the most common of those 4 for you to get. So chances are pretty high you're going to get this skill. Pretty high, actually. I think out of the care plan sets, I'm pretty sure respirations is on 3 of them. So you got a pretty good chance. Most of the skills are only on 1. So this is one you probably want to practice. The good news is if you've got anybody living at home, this is easy to, even pets you can practice this with, right? Because they breathe. Don't do fish. Fish are a little harder, but you know, other pets breathe. Yeah, it's hard to hold a fish's hand. All right, so this is our care plan. We're going to follow it. We're going to start with reading the care plan. We're going to do our opening. We'll evaluate if we need gloves. And we're not going to tell the patient that we're counting their respirations. We're going to say vital signs. I'm here to take your vital signs. In and out is counted as 1 cycle. So That whole thing was 1. It doesn't matter whether you start at the beginning or the middle, or if you count it at the end, that whole thing counts as 1. Good? So if you go 1 as I'm inhaling, that counts the same as 1 in between and 1 at the end.
So every time the chest rises, that's
Is 1 whole cycle, right? Inhale, apex, exhale. The whole thing is 1. So if you have any part of that, it counts as 1. All right. Our care plan told us to count for 1 full minute. So how long are we going to count for?
1 full minute.
1, and why?
Doesn't care.
Care plan. However, we always follow that care plan. We do what it says to do, but just like pulse, if our care plan doesn't tell us to count for 1 full minute, we're going to go to the 15-second method. We count for 15 seconds as long as it's regular and even and normal. You would multiply that by 4 and get your minute reading. You cannot use the 15-second method if your care plan says 1 full minute. And this care plan does. We're going to record this reading. Our care plan told us to record the reading, and anything we count, we have to record because it doesn't do our nurse any good if we've got it in our brain and they don't have that information. So we do have to record. Your documentation sheets in your book is on page 168 if you want a big version of it, but you can see a little version of it on the step-by-step instructions, whatever page that is. I don't know. Page 48 has some information on documentation. This is something I do want you guys to read over the weekend. Okay. Very few things do I assign in this book for you to read, but this is one of them. You definitely want to give this a good look. And then the next page, page 49, is on military time. If you don't know how to do military time, page 49 will help you out with that with a little activity. And I have a lesson that I'll be putting into the online course in the next couple of days on military time that gives you a lot of activity, interactive activities to apply military time to. All right, remember, this care plan is only for this patient. So that's it. That's all of respirations. It's all I have to teach you. Read the care plan. It says count for 1 full minute. We'll count their breathing for 1 full minute, not telling them that we're counting their breathing, and holding their wrists so they don't think that we're creepy. You're going to finish it up with your closing. Make sure you document. That's the whole skill. They give you 5 minutes to do this skill. Doesn't take 5 minutes to count for 1. So don't rush. Bless you. If for some reason on any of the counting skills, pulse or respiration, if for some reason you lose count, your brain fritzes out because you're being tested, you lose count, you're not real sure if you counted something. If you have to start over, you can. Tell the patient, I'm so sorry. I seem to have short-circuited. I'm going to restart. However you want to put it, but tell the patient that you're restarting. The evaluator's pretty smart cookies. They'll keep up. Look at the clock, pick another starting point, say start out loud so everybody's on the same page. And then count until the second hand goes all the way around. Good? Easy. All right, I'm going to show you this video. Now, you'll see the video. It'll look like I'm taking the pulse. I'm not. I'm counting their breathing. But for the sake of visualization, to make it easier to see the breathing, when the patient's laying down, it is easier to see breathing than somebody sitting up. So for the test, they'll have the patient laying down to make it easy. But you can also put an alcohol pad on their stomach, and that increases visualization. It makes it easier to see. It doesn't affect their breathing. What it affects is your ability to see it. I've used psychology on you. Your eye is drawn to movement when it's a contrasting color. So it actually makes the visualization easier. Now, you're going to watch this video, and on the video, at the bottom of the screen, just like with Pulse. Remember with Pulse, I had count with me, and the words got bigger and smaller based on what I was feeling. Well, this time, you're going to be watching the chest rise, but on the bottom of the screen, you'll see the same increase and decrease of the font to show you when he's inhaling and exhaling to make it easier for you to visualize. See if you get the same number that I got. Okay, go ahead, Jake.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. I need to get your vital signs. Is that okay?
Yes.
I'm going to close your curtain. Let me go wash my hands, and I'll be right back. Okay, Mr. Jones, I'm just going to lay this on your stomach for later. I'm going to elevate your forearm, keeping your elbow on the bed. And this will take me about a minute. I'll need you to remain quiet during that time, but I'll let you know as soon as I'm done, okay? And we're going to start. Ready, set, start. Stop. Thank you very much, Mr. Jones. Is there anything else I can get for you while I'm here?
No, thank you.
Are you comfortable?
Yes, ma'am.
Would you like a magazine before I go?
No, thank you.
Okay, bed's in the low position. The environment is clean. Here's your call light. If
Thank
you
you.
need anything at all, just press that red button. We'll be happy to help you. I'm going to go ahead and open the curtain and throw my alcohol pad away and wash my hands. After washing my hands, I'm going to document on the sheet provided by the evaluator and then wash my hands again. After washing my hands a final time, I'm going to review the care plan, think about my skill, make any corrections, and then tell the evaluator my skill is done. one for 15 seconds and then count the, like count pulse for 15 seconds, multiply that by 4, count respirations for 15 seconds, multiply that by 4, and now you got both of your readings.
Okay, thank you.
Don't try to do them both at the same time because it gets really, unless you're super hyper focused, and it'll get messy in your head when you're trying to count pulse 1, 2, 3, 4, 5, 1, 6, 7, 8, 2. It's hard for your brain to count two things at the same time without losing count. So that's not preferred.
It sounds like you could technically use your fingers to follow along with the respiratory count, right? It's like 15 to 20.
You can, yeah, but it's just much better, yeah. I'm going to tell you, in very, very, very few situations will you be taking a manual pulse anymore. Very few. Most places do not have CNAs taking a manual pulse. And I do expect within the next few years that gets removed from the test completely. I think they're going to replace it with donning and doffing PPE. So gown, mask, eyewear, gloves. I think that is something that they will probably do in the next couple of years because pulse is an outdated, antiquated, a manual pulse is an outdated, antiquated measurement for CNAs. Remember, CNAs do normal. There are situations where we still need a manual pulse though, but that's not normal. CNAs do normal. So who would be the one that has to take a manual pulse? The nurse. And therefore, it's no longer a CNA modality. So it would be more likely that they'll take it off completely. Good. Yeah, so don't worry too much about taking both of them at the same time. You're in a clinical setting, you're never going to have to do that. You'll use pulse ox and count respirations. All right. So on my main website, foryourcna.com, I have detailed test registration instructions for you. So if you go over to the testing tab, which is testing is going to be under testing. If you open that tab up by clicking on it and you look down, you'll see test registration instructions. I have 2 presentations on there. One of them is a video where I literally do a test registration on the screen in real time. You get to see the form. You get to see what I put in the form where, but it's kind of hard to keep up with because if you're watching the video, how do you do it at the same time, right? You constantly have to pause the video and that's annoying. So if you scroll down, watch it all the way through first so you know what you're doing. Then scroll down the page a little bit and I have a step-by-step slide-based presentation with screenshots of everything you just watched.
Where do we find this?
Right here on foryourcna.com under the testing tab, test registration instructions, but you'll also get a direct link today in your after class wrap-up emails. Okay. I try to make this so easy for you guys. I really do.
So I see like on here it says to obtain a background check. What if you had one within the
We're gonna
past year?
We're going to talk about background checks in 1 second. I need you to know where to go for this though. All right. So I'm not using this page anymore, but it has some information that you have on the, I've got to change this graphic, the colorful graphic that you have in front of you that has 1, 2, 3, 4. Okay. The 1 is in blue, 2 is in pink, 3 is in yellow, 4 is in green. These are test registration instructions. What's on here is what I used to give you on here. There's a whole lot more words on here. This is way simpler. It's to the point. Okay. So what you have is better than what I've got up here. But there's essentially 4 steps to the registration process. The first step is to get a background check. The second step is to complete the registration. There's 2 ways that you can complete the registration. There's a paper application, which Jake just handed to you. And there's the online registration. I highly recommend that you all do the online registration, which is the paper registration you have in front of you. It's just online. It looks exactly the same. All the same boxes there. There's 2 differences we're going to talk about as we go through this. We're going to use this paper one so I can tell you what to put where. You're going to use this as your template. but I highly recommend that you actually do the online registration rather than mailing this in. If you mail this in, it extends your test date about 3 weeks. It's way quicker to do the online.
What's the website that we go to?
I'm going to
Okay.
cover it. I
Okay.
promise you I will cover absolutely everything.
What was I gonna
I'm sorry.
It's okay, I'll come out.
Yep, just flag me down when you get there. All right, so here is our website we're going to go to. Prometric.com/exams/nurse-aid-FL. The paper registration that I gave you has it on there. That's their old, yeah, it doesn't matter. If you type in what's on there, it'll redirect you to this. They changed their format a little bit, but this is the actual website, but the one on the application will still get you there.
What if we've already done a background check?
We're going to talk about that 1 second. Okay. So Prometric.com's website. When you go onto this website, you're going to see some accordions. There's 5 accordions there. If you click on each heading, it'll open up and there's a lot of information on each one of these. But when you go to the website, they're all closed. You see the plus signs. Plus signs means you click on it and you get more information in that section. So when you're on this website, if you open up the application process, you'll see paper application, which is what I printed off for you guys, and online application, which is where you would go to apply online. That's where we're going to go to apply. So the first thing we're going to do is get our background check, and then we apply for the test. And that's very cut and dried. It has to be done in that order. There's no deviation here. First, we get our background check, then we apply for the test. Now, some of you already have a background check. You've done a level 2, maybe for healthcare. You've got something somewhere. The problem is, if you go onto the Board of Nursing's website, I'm being very specific here in my wording. If you go onto the Board of Nursing's website, which is floridasnursing.gov, and you click on FAQs, frequently asked questions, one of the questions on there that you're going to see is, what if I already have a background check? And their answer is very clear, unequivocal. According to the statutes, every applicant has to have a new background check. Now, I'm not going to tell you that you can't get away with using your old one. I've had people that were successful. I'm telling you what the Board of Nursing says on their website. Their website is very clear. Everybody needs a new background check upon test application.
So we should have a background check before we apply.
Absolutely. First, we do the background check, then we apply for the test. It has to be done in that order.
And the fingerprint.
That's what a background check is. We're going to talk about that in a minute.
So for the people who did like get their way with their old test, can I like apply and then they'll just disapprove me if I need to go get a new background check? Or how would that work?
Let me explain this, and this might answer your question, and then I'll come back to it if it doesn't, okay? So what happens when you go get a background check? That's what this is going to tell us, okay? So when you are applying for the test, what happens is that when you send in your application, it doesn't go to the Board of Nursing. There's 3 players in this drama. There's you, the applicant. There's Prometric, the testing company. And actually there's 4, really, if you want to be, I guess, technically correct. So there's you, there's Prometric, there's the clearinghouse who holds background checks. It's all their filing cabinet. That's all they are. The clearinghouse is a filing cabinet. And then there's the Board of Nursing. So we've got all 4 players here. You apply. That's what you do. You apply for the test. When you apply, that goes to Prometric. Prometric then has to go to the clearinghouse and pull your background check. They put that with your application. They make a packet. They send that packet to the Board of Nursing. Somebody at the Board of Nursing, and this is a human eyes-on event. This is not automated. This is a human event. Somebody, a real person, gets your packet and they look at your application and your background check. And that human has to decide whether you are eligible to test. Now, this usually takes about 7 to 10 days because remember, it's not automated. This has to be a human event. So if they have a question, if they think, I'm not real sure, right? You've got something on your, background from way back when, but they just want a little more information. Because when we give you your CNA certification, we're actually saying that you are safe to go into grandma's house and take care of grandma with no supervision. Now, grandma has candlesticks and she's got checkbooks and she's got medications and she's got all kinds of stuff that you might be very interested in if you are not of good moral character. So this is a human eyes-on event. So you apply for the test. That goes to Prometric. Prometric goes to the clearinghouse, pulls your background check, makes a packet, sends it to the Board of Nursing. Board of Nursing says, yes, you're a good candidate. Stamps approved, sends it back to Prometric. Now Prometric can schedule your test date.
Is Clearinghouse on this website that you gave us, Prometric?
No, just stay with me.
Okay.
Just stay with me, okay? Do you guys understand the steps here? Okay. You apply. Prometric, who has your application, goes to the clearinghouse, pulls your background check, puts it with your application, sends that to the Board of Nursing for approval. That is the process. I did not tell you to send in your background check to anyone. Notice the only involvement you had was to apply for the test. I want to be very clear on this. Let's go back one slide. Our 2 steps are get our background check, apply for the test. They have to be done in that order. You guys remember me saying that? Everybody has to get a background check. Then you apply for the test in that order. Good. Then when you apply for the test, this is the process that's happening. You apply with Prometric. Prometric goes to the clearinghouse and pulls that background check that you had done in the last slide. You do not send anything anywhere. Clear? There's something called a chain of custody here. You cannot have access to your criminal information in between these 2 agencies because everybody has access to Photoshop. It has to be an independent third party that gets the background check and sends it to the clearinghouse where you have no involvement. Good? Okay. So this is what's going to happen during that process. Now, we're going to talk about the background check in just a minute. Put your background check questions to the side for a second. Let me explain this, and then we'll come back to the background check. So when you get your background check done and then apply for the test, that goes to Prometric. Prometric pulls your background check, puts it with, makes a packet, sends it to the Board of Nursing. When Prometric does that, when they get your application and your background check together, they are going to send you an email. They're going to send you a notification that says, your application is complete. We got your application and we found your background check. Complete. We are now sending it to the Board of Nursing for approval. So the line is going to say pending approval. pending approval. That means that we got everything we needed. It's complete. And now we're waiting on the Board of Nursing. We sent it over there. Now that can take 7 to 10 days for the Board of Nursing to do their job. When the Board of Nursing approves you, when they say, yes, you are good to go, and they send that back to Prometric, Prometric will send you another email. And that other email is now going to say, instead of pending approval, it's going to say approved. That means that you know now that the Board of Nursing said good to go. Now, you don't have a test date yet because that takes another couple days. Prometric will then contact the testing center that you're going to select and say, okay, I got a candidate here that's ready to test. What dates do you have? The testing center will give them a date. They will take that date, put you in that spot for that date, make your reservation, and then they're going to send you an email that says this is your date and time for testing. You do not get to pick. There is no reservation that you get to make. They assign it. It's first come, first serve assignment. If that date does not work for you, you can call up Prometric and say, hey, that date doesn't work for me. And while they're on the phone with you, they'll find a mutually agreeable date. But you have to do that right away. Because when you get your test date, you're testing usually about a week later. There's not a lot of lead time here. They don't tell you, okay, 3 months from now, you've got a test date. No, it's like the next week. And if you wait until 2 days before testing to call them up and say, hey, I don't have a babysitter, I can't go, they can't put somebody else in that slot, which means now it's an open slot. They're not making any money. You've cost them. So they're going to charge you. So if you get your test date and you know that does not work for me, you need to call them right away, immediately, and change your test date. If you do that, they usually don't charge you. Okay? If you wait and you don't give them enough time to be able to slide somebody else in that spot, they're going to charge you. Make sense? Do you understand this process? Okay. So when you get your test date, you're usually testing about a week after that, usually. Sometimes it's a little bit longer. We're going into the holiday season, guys. It does slow things down a little bit. So, you know, it might be a week and a half or 2 weeks, but it's not going to be very long. Everybody good? Let's talk about the background check now. I got a whole section on this. So that colorful paper with the 1, 2, 3, 4 in blue, pink, yellow, and green, turn it over. On the back side, you should see some little fingerprints. That's our clue that this is our fingerprint page. There's lots of places that you can go to get fingerprints done. There's lots of places. And Prometric's website, under application status, if you scroll down, it'll actually have it'll have a link to a website with a whole list of background check providers that you can go to. Do not, right here, right now, use the Sheriff's Department. Last December, I had an entire class that decided to use the Sheriff's Department because it was much cheaper. It was like half the price. So they told me we're going to go to the Sheriff's Department. I said, I don't think that's a good idea because I've had problems in the past. They said, no, they said that it's good. It'll work. I called up the Sheriff's Department. The woman I got on the phone said, yes, we do level 2 photo-enabled background checks for state licensing. No problem. Send them to us. So they went. Most of them did not end up testing until March or April. Can I say for sure that it was a Sheriff's Department problem? No, but it's awfully coincidental. So if you decide to use the Sheriff's Department for your background check, please know that there may be a conflict there and a testing delay. Now, the resource that I'm going to give you, I have no affiliation with this company at all. I get no kickbacks. I get no referral fees. I have no vested interest in this at all. But this process results in the quickest testing for my students. Okay, I've been doing this a long time, guys. I've got this streamlined for you. So Deontis or DTIS.com is our website. You've got it on the paper. The best thing to do, you can walk in. They use the UPS store at Barclay. You can walk in. No problem. You don't need an appointment. You can walk in, but they're going to charge you about $40 more to walk in. It is way cheaper if you go online and fill out their little form. You'll save yourself like $40. And to me, that's worth the 5 minutes it's going to take to fill out this form. Man, if I could make $40 every time I spend 5 minutes, ooh, that'd be all right. I'd be able to go on vacation. All right, when you go to DTIS, there's a little button there to register for an account. So you want to click that button. You're going to fill out the registration form. It's going to ask you for your email. You're going to set up a password, and then you have to go to your email and click that link so that they know that it's a valid email. Once you've done that, these are the list of, basically this is what I use to make your sheet there. Once you do that, once you go to their website, I thought I had it on here. No, I don't. Okay. So once you go to Deontis's website and you register for an account, you're just going to go through all of the screens. But there's a couple of things on those screens that are a little bit confusing. Like they're going to ask you what your ORI number is. I've got it on that form for you. It's EDOH0380Z. You have to use that. That code is what tells Deontis or DTIS. It tells them this background check is for the CNA state exam. So when it goes into that filing cabinet at the clearinghouse, it goes into the right filing cabinet that Prometric has access to. If you have a different background check, it may be in a filing cabinet that Prometric does not have access to. That's why they require a brand new background check for every single application, or, for every single applicant. Does that make sense? It's got to be in a filing cabinet at the clearinghouse that Prometric has access to. By using this code, you're getting it in the right place.
This is just specific to me, but if you're in the process of changing your last name and like changing your social security, should I wait on doing this? Like get my stuff that I need to do first and then?
And that's going to be really hard with the government shutdown right now.
Oh my gosh.
So you've got two options. You can register in all of your current information, whatever you have now that proves who you are, your driver's license, social security card. And then once you've made that change, you would submit that information to the Board of Nursing, but you have to send originals. Okay, so original court order, original divorce decree, and original marriage license, whatever the case may be. You have to send originals. And a lot of people don't like to send originals through the mail.
Okay.
Or you can wait until you get the whole process done and then register under the new content.
Okay.
So you'll have to figure out which one makes more sense to you.
I just have a question about filling out the paper.
We're going to get to step by step how to fill out. Yep. Do you guys understand the whole process, how it works?
Yeah.
You do your background check using these instructions. You register for the test using the instructions on the other side of the sheet. We're going to go through the test registration process step by step right now. We're going to skip certain sections that I don't need to help you with, like demographics. I don't need to help you with that. But we are going to focus on the sections that are going to be problematic for you. Okay? $76.50 if you register online. If you walk in, it's something like $120.
I just paid $87 a month to go to get them done.
Yeah, and I can't, I mean, all I can tell you is what the Board of Nursing says. I have had people that have ignored me that just registered for the test, and Prometric was able to find their background check in the clearinghouse. There's a possibility, but if not, it's going to delay your testing. All right. So the online application is exactly like the paper application you have in front of you, except for two things that we're going to get to a little bit later, but everything else is the same. So this packet that you have is the application. So let's talk about it. Make sure you have 2 forms of ID and the name matches. I'm not going to get into that. This section is for if you need ADA accommodations. So if you need a seeing eye dog, a sign language interpreter, or something like that, fill out that packet. The bottom is your demographics. That goes on to the next page. You can fill that out on your own. I'm not going to help you with that. Let's go down to the bottom of page 2. This is where it starts to get a little tricky. And you probably want a pencil or a pen to make notes here on your form. At the bottom of page 2, it has the Medicare and Medicaid fraud questions. This is based on as a provider. If you've never been a healthcare provider or worked in healthcare, the answer for 1 and 2 is going to be no. I'm sorry, let me back up. I got ahead of myself. Questions 1 and 2 are about felonies. If you have a felony in your background, see me after class. If you have no felonies in your background, 1 and 2 are no. 3 and 4 are about healthcare providers. If you worked for a healthcare provider that got caught with Medicare or Medicaid fraud, these might apply to you. And we just had 2 of our local doctors that got picked up for Medicaid and Medicare fraud to the tune of something like $12 million. So if you worked in their office, this is going to be a little bit tricky for you. You're going to have to answer these questions.
So the answer is no.
If you've never worked,
Right, if you did.
right, if you never worked in healthcare or you never worked for a healthcare provider that got caught Medicaid fraud, the answer is no to 3, 4, and 5. Sad but true. All right, so let's go to the next page. 3, 4, and 5 is on the next page. So if that didn't apply to you, 3, 4, 5 is no. Leave all the A's, B's, C's, D's, and E's blank. Don't fill those out. You only fill those out if you answered yes to the question above.
Mine is going on the disciplinary history, like the next box right
Yep.
I'm a med tech at my facility, so would I mark yes on these since I do have that certification? Or would it?
It's asking you if you've ever had any disciplinary action taken against a certification in Florida or any other state.
Okay.
So if you've never had a medical certification anywhere, the answer is no to all 4. If you have let's say you're a medical assistant or a med tech or an occupational therapist or something like that, if you've ever had any disciplinary action taken against your certification, you would declare it here. And I actually, I used to kind of skip over this, but I had a student about 4 years ago now who had been an occupational therapist back in another state. And she actually had disciplinary action, had her license removed from her for sexual impropriety with a patient. And I don't know the specifics around it, but that's what this section is all about. Because if you've had a history of bad decisions with patients, we're going to look at you a little closer, right? Because you have a history of that. So that leads me to the next section, criminal history. Criminal history. Do you have one or not? If the answer is maybe, it's probably yes. Check off yes or no. The second question is going to ask if you've had your records sealed. So you made some problem, you had some problems, you had a criminal history, but you paid a lawyer $5,000 to make it disappear. I'm going to tell you, we're still going to find it. I don't care what that lawyer promised you, it will still be found. You have to declare it here. Doesn't matter, declare it. Declare it, because if you don't declare it, you are lying on your application. And they're going to look at that a whole lot different than if you have something and it was 20 years ago. We don't really care. Everybody was young and dumb. Everybody was young and dumb. Everybody has made some very bad decisions in life. Not everybody got caught. Okay. So if you have a criminal history from 20 years ago, you've been clean since, you did everything you needed to do, you've paid restitution, you've done your time, you did your community service, you paid your fine, whatever the case may be, they aren't going to look at that as a disqualifying offense. I mean, unless it was like murder in the first, you know. But it's what they're looking for are people that are actively going to put grandma at risk. If you have a shoplifting charge from when you were 17, you were young and dumb. If you have 17 shoplifting charges and the last one was 2 weeks ago, you've got a problem. See how they look at that different? Okay. All right. Last question is all about juvie. So that third question there is, do you have a juvenile record? All right, let's go up here to page 4. I can't help you with that. Read those questions, answer them. I'm not legally permitted to answer questions on page 4. That is all you. And it's what we call self-reported. Healthcare is stressful. They're trying to get a gauge on how you are going to work in a stressful environment if you have problems with stress. Just kind of makes sense. Bottom is your Social Security number. You can fill that on your own. And why is that up there? That shouldn't be up there. Oh, that's why. Okay. All right. Yeah, one page too far. All right. So page 5. I've already filled this page out for you on purpose. This is the one area that everybody messes up on test registration. So I've already done it for you. You will all register as E3 Challenger. When you are filling out the online application, do not put anything else there. I know you're sitting in a classroom. I know that. But you are still going to be a challenger. We do not do inpatient live clinicals in a facility. We're not that kind of a school. You will register as a challenger. I've already checked that off for you. I put a big X in the next section because you only fill that out if you checked E1 or E2. What did we check? Yeah, it doesn't apply to us, so move on down. We're going to register at a regional test center. So you'll see in-facility testing and then regional test center. I'm not keeping up here. Off to the side there, you're going to see a box that says test site code. The very back of your packet, I have a list of all testing sites in Florida, separated out by region. Oh, I don't have it on there? Okay. Yeah, I missed a page. All right. So, remember how I said that there's I know I'm running late, guys. Just bear with me. Remember how I said that there's a few differences between the online and the paper application? Okay. The online application is going to have a drop-down box. A drop-down box. So you're just going to pick whatever place looks closest to you. For us here, Tampa is our closest location. So you might want to write down this code. TAMAIR. That is our closest testing location. TAM like Tampa, TAMAIR like airport, because it's by the Tampa airport. You can go to the Ocala one. If you go onto Prometric's website, yep, there's a testing center list. You can pull up and see what's near you.
With all these monies down here.
Do we just?
I'm
She's getting it.
I'm getting there. All right. So remember, on the online application, it's going to be a drop down. Just choose the testing center closest to you. Now let's go to fees. Okay. Now let's go to fees. Okay. Most of you guys should choose the first option. If you want the computer to read the test questions to you, like if you have ADHD or a reading comprehension problem, or if English is not your first language, choose the second option. So first option for most of you. Second option, if you want the computer to read the test question and answer choices to you, we call that oral. If you want the written test in Spanish, I don't have anybody in here. It's primarily Spanish, do I? Okay, skip that. First or second, pick one. Both of them are 155. Pick one, first or second. I will tell you that students tell me, I've had a lot of them that pick the second one. They just want the audio just in case, but they take the earphones off like after the first question because it's very annoying. You're trying to read something and somebody else is in your ear trying to read it at a different speed, and it gets really annoying. But those of you that need that, need it. There it is for you. Okay, good, good. All right. If you have to retest, if you fail the skills, don't do that. If you fail the skills and pass the written, you just have to retake the skills. You would check the box for clinical skills. Notice it's $120 to retest. If you have to retest for written, okay, if you pass the skills but failed the written, you should not do that. But if you do, you would have to pay $35 to retake the written test. So these sections are for retesting. Good? Good? Okay. On the online application, once you check, it'll ask you if you're initial testing or retesting. You're going to check one of those boxes. When it says, when you check the initial, because that's you guys, you haven't tested before, initial testing, it won't even bring up these retesting fees. They won't even be on there. All right, so $155 is what you guys are going to pay. Page 6, there's a box there that you have to check. You're also going to check it online as well. And it says that you have received and read their privacy policy. That is the page that is attached to your packets. Tells you how they're going to use your private information to clear you for testing and what to do if there's an error. There's an affidavit. You're going to sign and date online. You're going to sign virtually. That's fine. But at the very bottom, I want to bring your attention to something. It says if you do not receive an authorization to test, that's your test date, within 10 to 14 days of submitting your application, you have to contact them. When you call, they're going to tell you it can take up to 90 days to clear you. What does your application say? So you're going to tell them, my application says 10 to 14 days. I want a supervisor. You've got to get past the person answering the phone. They're going to give you some outlet, because their job is to get you to hang up. They're going to give you an outlandish answer. You're going to tell them, no, my application says. This is your contract with them. Okay. Good. Good. It also tells you on the Prometric website, if it's been more than 5 days since you submitted an application and you've not received a confirmation. Confirmation is what says application status complete. If you don't get that within 5 days of doing the application, you need to contact them. You need to find out why, what happened. Something went wrong. So there's 2 benchmarks. If you don't receive a confirmation in 5 days, call them. If you don't receive your authorization to test in 14 business days, call them. Those are your guidelines for timing.
What about our fingerprint? Do we take our fingerprint with us when we go to test?
You don't take your fingerprints anywhere. You go to the fingerprint agency,
Right.
and you get your fingerprints done. That's it. They're not going to give them to you. You don't take them anywhere. You don't send them anywhere.
When we get them in Prometric.
You are going to use that code that's on the paper I gave you, the
Okay.
ORI code. That tells them where to send them.
Okay.
Jacob, review sheets, please. All right, good. All right, that is the test registration process. Have a great weekend, guys. I will see you on Monday.
Homework?
Homework is chapters 5 and 6 in your book. It's on your syllabus. 5 and 6 in your book. Those of you who joined us online, thank you so much. We will see you for class 5 on Monday. Have a great weekend. Till next time, happy caregiving. Bye.